Better turn my sound on, I guess. Good morning, everyone.
Good morning.
Good morning.
Good morning.
There we go. Okay, that's weird. My camera's reversed.
Yeah. What is that on your desk there?
It's okay, like there's a lotion bottle. and
Oh,
There's a salt pepper shaker, and I don't know how to reverse the camera on this. Isn't that weird?
huh.
This is a Surface. Anybody else got a Surface?
Well,
Okay.
it should be a symbol there to reverse it.
I'm looking. I'm not seeing anything.
Any computer techies on that can help her?
I think I got it.
Everything looks good on our end, Mayor.
Yeah, so now y'all know what I keep on my kitchen table, a basket with napkins.
We've seen worse.
A few minutes ago, it was my big cat laying across the top of it, so.
That would have been fabulous. And the cat takes precedent.
Yes, he does.
Morning, everyone.
Morning. Morning, Stephen.
Good morning.
Okay, how are we doing with everybody here?
I think we're close, sir. Ryan, Victoria. Ryan, you're on mute.
Hi, sorry, I think we're good.
Okay. We're good to go?
I think so.
Yes.
All right. Well, good morning, everyone. I will call the meeting to order. And Ryan, if you would do introductions of guests and staff, I would appreciate that.
All right, Commissioner Anderson,
Here.
Dr. Clary,
Here.
Commissioner McKinney,
Present.
Commissioner Lindy,
He's in the building. He's probably still trying to get connected.
okay, Mayor Byers,
Good morning.
Councilmember Duval,
Present.
Dr. Atterbury,
Here.
Commissioner Lindy.
He is signed on.
Okay, we'll go back to him. Okay, Yakima Health District staff, Andre Fresco,
Here, good morning.
myself, Ryan Ibach, Chase Porter,
Present, good morning.
Melissa Sixberry,
Here.
Lillian Bravo,
Good morning here.
Sean McGee,
Morning, here.
Dr. Bard,
Good morning.
Nathan Johnson,
Good morning.
Jocelyn Castillo,
Here.
Victoria Reyes,
Here.
James Elliott.
Good morning.
And then we have three new staff that are attending, Jasmine Perez,
Good morning.
Stephen Newchurch,
Here. Good morning.
and Cindy Shampoo.
Here, good morning.
Okay, and then let's see, Sean, can you introduce Stephen Newchurch?
Yeah, absolutely. So Stephen came to us from, he hails from Maryland and recently moved from North Carolina, but he joins us as our newest environmental health specialist. So he's been at it for a few weeks now, learning the trade. There's a lot to learn in that position. So, but he's getting through it. He's doing well. And we're excited to have him and, get closer to being at full staff again. So welcome, Stephen.
Okay, and Lily, can you introduce Jasmine Perez?
Yeah, so Jasmine is our newest public health technician. She'll be helping in a few different programs, but primarily in the breast cervical colon health program. Jasmine graduated from the University of Washington, so I'm very excited to welcome another Husky. And Jasmine, you want to say a few words about yourself?
Oh, good morning, everyone. I'm Jaslyn. I grew up here in Yakima, lived in Yakima my whole life, and just a little fun fact about me, I love playing soccer and watching soccer, all about soccer.
Thanks so much, Jasmine. We're very excited to have you as part of the team.
All right, and Chase, can you introduce Cindy Shampoo?
Yes, Cindy is an accounting tech with us. She's actually been with us for about a year now. So we're just now getting back into staff introductions. And so I'm really happy that she's been working very hard for us for over a year. And I'm really happy to have her. She does a lot of the morning reconciliation for the front desk tills, and she does our accounts payable and many other things around here. So I'm happy to have Cindy on board with us. Cindy, you want to say a few things, please?
Hi, I'm Cindy, and I too grew up here in the Valley and went to trade school at Yakima Business College. If anybody is here old enough to remember Yakima Business College. And some of the things I like doing are cross stitch and traveling. So thanks.
Awesome. Thank you very much, Cindy.
I feel bad I didn't give Stephen the opportunity to say a couple of things. I didn't know that was part of
Glad
it.
you brought that up, Sean, 'cause I was
Stephen,
going to ask him.
Yeah, Stephen, you need to tell everybody a little bit about yourself.
Yeah, so as Sean said, I grew up in Maryland and went to North Carolina State for university. I moved out here with my girlfriend. She got a job out here at an environmental consulting agency. So that's really what brought me out here. And I'm just really happy to be at the Yakima Health District, and I'm loving it so far.
Good. All right. Well, welcome everyone, and look forward to working with you. All right. Well, we'll move on now to review of the submitted written comments, public comments. Ryan?
Okay, we did not have any submitted public written comments for this meeting.
Oh, wow. Okay. All right. Well, then we'll move on to consent agenda. Is there anyone who would like to make a motion on the consent agenda?
Move to approve.
Is that Mayor Byers?
Yes, it is. I'm sorry.
Okay.
I didn't identify myself.
Commissioner
is there-
McKinney, I'll second.
Okay, who's second?
Commissioner McKinney, I will second.
Okay, it's been a motion by Mayor Byers and a second by Commissioner McKinney. Any discussion? If not, all those in favor, would you like to take a poll? Ryan?
Okay, if you're in favor of the consent agenda, please state yes. If not, state no. Dr. Clary,
Yes.
Mr. McKinney,
Yay.
Commissioner Lindy,
Yes.
Mayor Byers,
Yes.
Councilmember Duval,
Yes.
Dr. Atterbury,
Yes.
Commissioner Anderson.
Yes. All right. Thank you very much. Now I'll move on to board business and Director Andre Fresco.
Yes, thank you, Mr. Chair. Good morning, everyone. Welcome to our October regular meeting. Thank you to the public for joining. I did want to first express my appreciation. It pleases me that we have new staff and staff like Cindy who have been serving admirably during this coronavirus response. It's really rewarding for us to be able to attract and retain quality staff during this time. So my appreciation to all of you. And Jaslyn, I can yell goal very loud and very long. So we'll have to spend time. I'd like to begin by just sharing that I'd like to make brief remarks because we do have a packed agenda, but I did want to give an overview around coronavirus specifically. since we met, there have been a number of changes that are dramatic, not just for our county and our state, but our country. They also have to do with a number of things. The first is that boosters are approved. It is, albeit a little confusing about how the booster process will work. So I'll defer to Nathan on our staff and certainly Nurse Sixbury and Dr. Varg in terms of how we move forward with explaining this to the public and certainly to the board. We have the process of allowing for boosters in Moderna, Johnson & Johnson, Pfizer, but it is a bit complex. So I just want to share with you that there is going to be a lot of discussion, certainly from us with the community and around the state, because there's the potential now to mix and match different vaccines, and certain vaccines are going to be at different dose levels for the booster. So it's a bit complex. I did want to introduce that though. Any quick questions I can answer on that? Okay. The second is that there's now a push to allow for vaccinations with Pfizer for children 5 to 11 years old. That is a very new development. We're still in the process of working through that, but that would allow vaccinations, albeit at a different, again, dosing level for Pfizer. And that is a large opportunity for young folks to remain safe. But there is complexity around that, and we are working through that as well. So we have received many discussion points on this, but not all the go-aheads that we need to make certain that this works well. So the bottom line is that that is being approved. It's clear that it's necessary, but we want to make certain that we have all of the approvals in place.
Andre, I do have a question about that. When you say that there's
Yes,
a
ma'am.
push for it, who's pushing for it? And when you say that it's clear that it's necessary, can you be specific? What are you referring to that it's clear that it's necessary? The full approval is necessary, or it's necessary to vaccinate children?
I guess I would mean both. The Biden administration has been very forward about their interest in having that vaccination available. The medical community has been very forward about wanting that, but we are not yet at a place where we have all the full approvals that we need. And again, Nathan and Dr. Barr can go into specifics on that. In terms of my feeling that it's necessary, there are many children who are at risk of getting sick. So the idea that there's an opportunity to vaccinate children and have them be safe when they're in school specifically, I think is an opportunity for our entire country to be safer, and we certainly want to protect children. So that's what I meant by it's necessary.
I just want to make sure it was clear you're sharing a personal view.
No, I'm sharing a professional view. The choice to vaccinate is the parent's choice, but professionally, I feel that it's our responsibility to keep children safe. And certainly the goal of vaccinating children, as we've done for many, many years, is to ensure that their longevity. Are there other questions I can answer? Okay. Commissioner Anderson, I think that's all for the Yakima County COVID update.
Okay,
If you'd like to move, we can move to the budget hearing and adoption.
yes, let's move to that.
Thank you, Commissioner. So our goal every year, as we've shared previously, is to adopt a budget in October. We have the opportunity through the end of the year, but it allows us to plan safely and well for our fiscal productivity. Our process is to have hearings that allow for public discussion. So we had a fee hearing already, as you're well aware, and now we're going to have a budget hearing. So I'll pass that on to Ryan.
Okay, so at this point, Commissioner Anderson, we just need to open up the budget hearing.
Okay, I will now open the hearing for the budget report.
Okay, we did advertise the budget in the newspaper and also in we advertised that there'd be a public hearing, and it was also on our website, and we did not receive any input from the public.
Okay. All right, so what's the next step then?
So we can close the budget
Okay.
hearing, and then we could discuss the budget.
Okay, I will now close the budget hearing and then we'll ask for discussion.
Thank you. So again, our goal is to bring the board our budget, and our hope is that you will adopt it. So that's here for a board decision. We shared the preliminary budget with you last board meeting, so you've had it to review. We can certainly answer any questions you have. It's admittedly a large budget, larger than we've ever had, but that is largely due to COVID. That is our goal, is to have the privilege to serve the community's needs safely and well. And that's why you're looking at a $20 million budget. But we entertain any questions that you have, and certainly Ryan and Chase, if you'd like to share thoughts, please do so.
If it pleases the board, would you like me to do a quick review of the budget I presented last month?
Chase, can you tell me, is there any change from the budget that you presented to us last month?
No changes.
Okay, thank you. I have no questions then.
Any other questions or comments?
I don't really have a question per se if there were no changes. I still think maybe a quick run through one more time would be good, Chase.
Okay. Jocelyn, will you please move to the budget? Yeah, so the first page we have here is our full-time equivalents. This is our base staff that we would need to meet, have mandated services, which is 33 FTEs, including our attorney. Next slide, please. Because of COVID, we've had to pull on a temporary staff. So we have expecting to have 11 full-time employees for 2022. And this is all COVID driven for these additional employees. Next slide, please. Here's our summary. Could you scroll down a little bit so we could see? Yes, this is a summary of our programs here. Our indirect is our admin staff, myself, and pretty much everybody on this meeting that is Board of Health staff. And then our direct programs are our programs that are either funded directly or mandated services. So yes, can you scroll down just a little bit more? As you can see, our COVID-19 response, they're almost about four lines down, went from 1.2 million last year to 14.5. And if you look down at the bottom right, which is a change of 13.3 million. And if you look at the bottom right, our overall total programs is the main increase is due to the COVID response. Any questions? All right, I'm going to move down. I'm not really going to address anything specifically. This was provided to the board and the public who requested it. Our directives are all our programs in detail. Really, the big ones would be our COVID. So we scroll down slightly. Right there is our major, we more or less started 4 programs in response to COVID, mainly due to funding sources, to keep those separate. Next page, please. Here's mostly our environmental health programs. Continue to scroll down, please. Development of disability, and our total direct budget. 20.4 million. Income statement, next slide, please. Could you scroll just, yeah, that works good. Can everybody see that okay?
Yep.
Okay, good. So as you looking at the revenue piece, there's not a lot of big changes. I mean, the main changes you can see is the addition of $13 million in federal. There's some changing of buckets from state into federal, and just kind of a expected slowdown in a way. Our expenditures were, as you can see, we have 11 new additional employees, and we're bringing on a lot of possible COVID battling programs. So that's going to be your large increase in professional services, other increase of about 12 million, and that's about pretty close to the bottom. Next page, please. Here's our final budget of 20.4 million, but we like to have an enhanced piece, which is help to spend down any additional reserves. So a full budget of $20.9 million.
And if I may add, Chase, the dramatic increase in cost is due to a number of things, but one of them is that we are having to pay directly for and then being reimbursed by FEMA through the state for these services.
Yeah, we need to keep in mind that when both the testing sites and the vaccination site, when the state guard came through, FEMA paid for all of that. So that was not included in our budget, and that's not in our financials because that went through all of FEMA. And so that's probably not going to happen again. I don't expect FEMA to be showing back up again, or the National Guard. And so a lot of those programs that are going to be needed going forward are going to be running through the health district. And that's the driver of this main increase.
Okay.
Commissioner Linda, you had some questions about the COVID budget. Did you want me to get into that a little bit more? Is there any more questions about the overall budget?
I don't have any further questions. Yeah.
I have a question about it. Last year, I think you had like 29.9 FTEs, right? Before the pandemic. How much has it changed?
Well, I want to say last year we actually had 32 FTEs. So mainly it's just been one additional FTE, and that has to do with Dr. Barg. Our health officer has been an independent contractor, but due to insurance purposes, he is actually a YHD employee. And then the additional 11 is a lot to do with our COVID response. We've had a higher outbreak response. We've hired an epidemiologist, and there's been quite a bit of paperwork generated with all these things. We got to keep track of more stuff, and so we've had more admin staff, accounting staff added.
Any other questions?
For the I do. So for the Yakima Valley population and the people that we serve, compared to other counties, how do we compare as far as FTEs, and how well we can serve the people?
Ms. Duval, if I may, thank you for the question. I think it's a pertinent one. We are much larger in geography and population size than many of our neighboring counties. So we have more employees sometimes than neighboring counties like Klickitat. But in terms of the size of our staff, I would say that we're rather small when compared to a medium-sized community. 250,000 is considered a medium-sized community, certainly in this state and other states. We are decidedly small. That is because of literally decades of reduction in coverage for public health work. And so those reductions in the buckets that cover public health has been why we've been pushing so hard over the last 6 years for what we refer to as foundational public health services, which is an investment in new staff, new technologies, new abilities to serve the community. So our expectation is in the coming years that with state funding, foundational funding, if that remains constant, we should be able to grow and address many of the needs that our community that are very complicated and take a multi-year solution. Did that answer your question then?
Yes, I just hope that, we make public health a priority and make sure that we have the FTEs necessary to be able to serve everyone well.
Yes, and Ms. Duval, I'd like to add too that our fiscal responsibility is to ensure that we have the funding streams that allow us to hire staff. We are majority union staff here, so when we hire someone permanently, we have to make certain that we can retain their job, and we want to train people well, and we want them to have a long tenure at the health district. But it is difficult to hire new staff when you don't have the funding long term to project that you can retain them. So that is our goal. I will say that One of the confounding things for us, and this is a question that we've received from the board many times, which is what is our future? What are we doing to plan for post COVID? And because the COVID response is so enormous, we have had less time to do that type of planning. And admittedly, the state has had less time to discuss future funding opportunities and plans for investment in the public health system. But it is a top priority, not just for the state, but for the nation. Thank
Okay. Any other questions or comments? Hearing none. Is there a motion?
Mayor Byers, I move to approve.
Nyla Duval, I second.
Been moved and seconded to approve the budget. Any further comments or questions? Hearing none. Ryan, would you take a poll, please?
Okay, if you're in favor of approving the budget, state aye. If not, state no. Dr. Cleary,
Aye.
Commissioner McKinney,
Hi.
Commissioner Lindy,
Aye.
Mayor Byers,
Yes.
Councilmember Duval,
Yes.
Dr. Atterbury,
Aye.
Commissioner Anderson.
Aye.
Vote is
Motion
7-0.
passes. Thank you.
Awesome. Thank you so much.
We'll move on now to the number 6 financial report by Mr. Chase.
All right, thank you very much. Justin, will you move down into the financial report section, please? One more page. So for the month of September, we had $132,000 gain. We had another $50,000 deposit from the Group Health Foundation. That's one of the main drivers in that increase in 132,000, bringing our excess revenue to 273,000. I like to compare what it was and what it is, right? So fiscal year 2021 adopted budget of 7.5 revenue and expenditures. So that was our originally adopted budget. We've since adopted an amendment, but originally it was 5.6. Our total actuals right now are coming in at 9.7 for revenue and 9.4 for expenditures. So we're a solid $4 million over budget compared to if we didn't have that amended budget. As you can see, this is a much needed large budget for 2022. Next page, please. Moving into the income statement. Again, it's a lot like we've seen this entire year. It's a really COVID-driven income statement. Our federal funding is at $1 million for the month of September. Next page, please. Coming to we spent $1.3 million total for the month of September. So looking at that, we have a year-to-date of expenditure of $9.4 million and a 2020 amended budget of $14.5 million. So for the last 3 months, we have $5 million left, which is actually kind of tight. Looking at, if we continue with our current trend of $1.3 million per month, we'll have spent up $4 million by the end of December. So that would leave us about $1 million in wiggle room. The issue that we're seeing though right now is having to increase services. We're talking about booster shots and additional testing. We've actually had and other, like UW was paying for testing and for testing here at the Yakima site. So that might come back to us. So $1 million for the last month is not a lot of wiggle room. So I'll be watching that closely. I'm hoping to not have another budget amendment for 2021, but there is a real possibility that we will need another 2021 budget amendment to finish out this year. Is there any questions about that? All right, hearing none, I'm gonna move on down into the program pieces. I'm not really going to touch on anything here as we've seen in the past. We're just spending a lot of money in COVID. That's kind of our fight right now. Keep scrolling down, please. Any questions about programs? All right, last page, or second to last page, I'm sorry. Here's our COVID expenditures for September. $900,000 directly for COVID. So that's almost $1 million. So we are spending a lot of money. And this is vaccine, testing, just the fight. Last page, please. As Andre said, explained earlier, that we're spending the money now and getting reimbursed by DOH, and you can certainly see that in between August and September. There's a big drop off of our reserve funding, but I'm expecting that is being reimbursed. FEMA has been reimbursed us. We've got reimbursements from them, so I expect that to level out or tick up a little bit next month.
Jason, if I may add, please, we are fortunate to be partnering with the state with FEMA reimbursement. Normally, you do not receive full reimbursement from FEMA during disasters. The state is making certain that we're made whole, so we receive 100% reimbursement, and it's a far quicker turnaround than anything I've ever seen. Thank you.
Yeah, thank you for that, Andre. Is there any more questions? Okay, thank you.
Mr. Chair.
Is that your report, sir?
Yes, sir.
Okay, great.
Mr. Chair, if I may add something.
Yes.
Thank you, Commissioner Anderson. I don't believe that we have shared with the board the results of our audits, and I'd like to do so. Chase is hardworking and quite humble, and our team is always making certain that they are working for the best interests of the district and the community. But I did want to share the good news that we have completed 3 audits for this year, or for last year, but this year we've completed 3 audits, and there were no findings. They're all clean audits. I wanted to share how fundamentally difficult it was to do 3 audits. Completing 3 audits, a compliance audit, a fiscal audit, and a single federal audit is unprecedented in the middle of a disaster, in the middle of converting to a new financial management system. The team never complained. They did the work, and it is amazing that we've had so many new and complicated funding streams coming through the health district, and it's all been managed well. So my appreciation to the team, and I did want to share the good news with the board.
Well, that's great. Thank you, Andre, and congratulations, Chase, and others, everybody that worked on that.
Yes, thank you. Certainly a lot of gratitude goes to my team. We have a very good team. I will say that Yakima Health District is kind of a weird time warp. Like, feels like Cindy just came on and we completed those audits years ago. So it's strange. I got to admit that. So forgive me for not bringing that up earlier. But yes, we had some very good audits. And so 2020 was a really hard year, as you guys all know. And we brought Workday live in the middle of a pandemic, which is crazy, but it was successful. And so a lot of gratitude there for Yakima counties helping that. And then yeah, just three audits for 2020. So happy to have that over with. So yes, thank you.
Congratulations.
Well done, Chase and team.
Yeah, I would say the same. Having sat through some of the city audits, I know how complicated that can be, and just appreciate all the work that you and the team have done. And to have 3 audits with no findings is an achievement. So congratulations.
Thank you.
Any further comments? Hearing none, I'll entertain a motion to approve the monthly report for September 2021.
I will so move. This is Commissioner Lindy.
Mayor Byers, second.
Been moved and seconded to approve the budget as presented by Chase for September 2021. Any further comment? Hearing none, Ryan, would you take a poll, please?
Yes. Dr. Clary.
Aye.
Commissioner McKinney.
Aye.
Commissioner Lindy.
Yes.
Mayor Byers.
Yes.
Councilmember Duval.
Yes.
Dr. Atterbury.
Aye.
Commissioner Anderson.
Aye. Thank you all. Appreciate it.
Thank you.
Well, now we'll move on to department reports and Chief Operating Officer Ryan Ibach.
Okay. So for schools, in the month of September, we saw a significant decline in the number of cases, the case rate, and the number of cases of school-age kids. However, in October, we've kind of seen that leveling off. And so we were seeing about a drop between 100 and 200 in cases over the month of September. But now we're kind of seeing it holding steady. We did see last week, we saw 318 cases in school age kids, 5 through 18, which was 23% of all the cases in Yakima County. Of those 318, 142 or 45% were in the K through 5 grades. So we're still seeing quite a large number in the K through 5 grades. We still are seeing, we're seeing a little bit of a decline in the number of students that are infectious while at school and the number of staff that are at school. Each week we get a handful. The last couple of weeks, it's been 1 or 2 cases of on-site transmission in school. So that's relatively low. We did see 2 class closures last week, and we haven't seen a school closure yet this year, which is good. And it's been about 3-4 weeks since we've seen an athletic team quarantine. So that's good. We do know that we are heading into the winter sports season where there's high contact sports such as basketball and wrestling. So we'll definitely be working with the schools with those sports and those sports teams. One thing too to report is hospitalizations in the 0 to 19 age group last month saw a record high of 14 in 1 month. Happy to report that so far this month there have been 3. So we are seeing a decline in hospitalizations in school age kids. Any questions on schools? Okay. And then the last thing I have is the December is the month where we do a review of our executive director, Andre Fresco. And so we will be doing sending out evaluation forms to the Board of Health to do an evaluation. And in December's meeting, regular meeting, we will be having an executive session to discuss the performance of a public employee. And that's all I have.
Thank you, sir. Next, we will hear from Nathan Johnson.
Good morning, everybody. Just real quickly on as it relates to testing, we do now have the State Fair Park site up and running. It's going well. We've received a lot of positive feedback from the community for bringing back a drive-through option. So we still have those other 2 sites, the College site through Memorial and Signal Health, and then the Sunnyside site through Columbia Safety. And those are walk-up sites. They're all prepped for the winter. They have tents out there now, and anticipating for some colder winter coming up. In terms of boosters, Andre alluded to it a little bit earlier. It's a little confusing, a lot coming fairly quickly. So I'll try to give high-level updates. End of last week, there was a lot of approvals that came through that included Moderna booster for all the same groups as the Pfizer group or Pfizer booster, which includes high risk people who live in a high risk setting or work in a high risk setting or have health conditions. The Moderna booster is a half dose compared to the Pfizer, whereas it's a full dose. But it is the same time away from the second dose, which is 6 months. So both Pfizer and Moderna, it's 6 months after that first dose, or 6 months after the second dose for the booster. J&J was also approved for everyone 18 and older across the board who received that vaccine, and that's 2 months after they received that initial dose. And again, that's a first dose as well. There is also approval for mixing and matching. It has been found safe and effective for people who want to get that booster dose of another vaccine. That doesn't mean, or that still means that you finish that initial series. So Pfizer and Moderna, you get those same first 2 doses of the same vaccine. And when you get that third booster, you can switch it up if you would like. All these boosters, booster news is when they get approved through the FDA and then the CDC and then certainly the Western Pact, or as soon as they get approved by the CDC ends up creating a standing order for these. And these orders traditionally throughout this response have came from the CDC within 24 to 48 hours of their approval. We have still not seen a CDC standing order on this. So for that reason, our mobile team specifically through the health district are not providing that those boosters yet. They are allowed to do the Pfizer boosters, but they're not mix and matching, and they're not doing Moderna boosters at this point. Healthcare organizations on their own can either use the CDC standing orders, or B, they can create their own internal standing orders. So we have seen some healthcare partners throughout the county and certainly throughout the country that have already started moving on those new approvals, some as early as Monday of this week. And as the days progress, more and more are getting on board. So we've been in conversation with the state. We hope to have that CDC standing order within the next couple days. Again, it's abnormal that it's not out already. So we could get Dr. Bard to sign a copy of that as well, so we can have our mobile teams start applying those new guidances. Also, in terms of ages 5 to 11, a FDA advisory committee yesterday did approve the use of Pfizer vaccine for ages 5 to 11. That advisory committee is now presenting it to larger FDA leadership, but with the anticipation that FDA will approve it within the next day or so. And then next week, ACIP, which is the American College of Immunization Practices, they will be meeting on that as well. And then following that, it will go to the Western Pact for their approval as well. Regardless, though, we're seeing that the approval of ages 5 to 11 specifically for Pfizer will be coming within a couple weeks. DOH has opened up pre-ordering for pediatric doses of Pfizer. For our county, we have about 31,000, a little over 31,000 community members within that age bracket. And we had 10 organizations put in a pre-order for an amount of right around 6,900 doses. This will be an allocation based off of a social vulnerability index, population, and all those other things that played a role way back last December when adult doses were in an allocation period rather than just readily available. So we don't know how much of that 6,900 will be approved and we will see in our county, but we're committed to ensuring that we do everything we can to secure as much vaccine as we can to support not only our teams, but certainly our healthcare providers that are still providing vaccine opportunities throughout the county. So we don't know how much doses, we don't know when those doses will come. We don't know a lot of the specifics on that. The pre-order was open just for a very short time, so we got those orders in. And then with that, and I'm sure Melissa and Lillian will touch more on this, but we're also doing a lot of work around flu. We are anticipating that we will see more flu this year. Just want to remind everyone that we did not see a flu season since the closure of Astoria Regional. Astoria Regional closed in January of 2019 there. And then in March of 2020, we went into COVID. And then we had all of that following flu season. We had all those safety precautions of quarantine, social distancing, staying at home, working remote, wearing masks, that all reduced the rate in flu. So with that, we have less of that coming into this year. So we are anticipating seeing an increase in flu going in. And flu traditionally, outside of COVID, always strains the medical community, everything from EMS transports to hospitals to supply chains. So it's something we're watching closely and working with our hospitals. And with that, I will pause for any questions.
Any questions for Nathan?
I have a couple questions. Nathan, for the testing side, I'm hearing that there are a lot of people who, of course, are needing to test for travel or being able to access events outside of our county that are requiring a negative test. So are we tracking what the percentages of tests for people who are arriving saying that they are either symptomatic or feared that they were exposed to COVID versus people who are simply doing it for reasons because they're required to provide a test?
Yeah, great question. It is not one of the questions that is screened. It is one of the things that I have the teams kind of just anecdotally keeping an eye on. And they do continue to report that majority of people are testing still because they've either been exposed or are symptomatic. There has been an increase specifically though for people who either want to go to an event or need that weekly negative test for their employer.
So how can we add that so that instead of anecdotally, we have real actual data that we can trust?
I'm not sure if that's a question we can add into the queue. It's something I'm going to have to take back to the University of Washington and see if that is something. They do have some requirements of what questions are allowable to be put into that questionnaire and what aren't. So it's something I can look into and certainly get back to you.
Potentially, though, it could be a voluntary, you wouldn't be required to respond, but if they included it, could be voluntary.
Yes, most likely it would be a voluntary question, regardless of if it's, if we do get it put in, it would be a voluntary question, not a required one.
And then
And Commissioner McKinney, oh, I'm sorry, ma'am. After
my
you.
next question, did you have a comment, Andre, about that?
Yes, thank you, Commissioner. I was just going to mention that I think one of the areas where we could focus on is the question of whether you are concerned about being symptomatic, because that is the question medically, which could determine whether someone's coming in who's concerned that they're sick. So that might help. Thank you.
My next question is about the vaccine approval that you're stating is forthcoming, and that would still be an emergency approval for ages 5 to 11?
Correct. Yep. So the FDA advisory committee that approved this, and it's going up to larger leadership at FDA for emergency use authorization extension. Yes, to cover that.
So I'm looking at the vaccination data for the age groups of 12 to 18. It looks like if the community order has been 6,900, that represents roughly 22% of the population between 5 and 11. That seems pretty high for an emergency approved vaccination group, when we're seeing data coming out that's showing that polling is showing that parents have reservations of doing an emergency vaccination for those age groups. So how much do we have concern of vaccine wastage concerning how long we can hold on to that? Because it seems like a pretty large order for that age group.
Yeah. So we don't know if we're going to even get approved for that 6,900. And again, that's going between just 10 organizations. So that's all of our FQHCs and not just their individual clinics, but as a organization. So that's one order for farm workers, one order for Astria Sunnyside, one order for Astria Toppenish, and so on. So we know that that 6,900 most likely won't all get approved, but certainly we also know that it's still most likely going to be a 2-dose vaccine, and having the ordering's kind of changed a little bit. So now instead of being very particular to order first dose and second doses, it's kind of all just one thing. So that 6,900 would probably also include our first doses and second doses for that age group.
Okay, that makes more sense. Appreciate it.
Any
Nathan,
further comment? Go ahead.
question for you, Nathan. So for people using these digital apps like Verify to verify their vaccination status, you're typing the information in on a computer and you're usually photographing or something your vaccination card. Can you, or do you know where that information is being compared against? In other words, is there a database repository where that is being verified depending on where you got your vaccine, or how that works? Because I have some people asking me that they've gotten vaccinated and they're having a hard time getting the digital wallet cards because they can't verify their vaccine was actually given to them, even though they have dates and times and lot numbers.
Yeah, great question. So the program that I'm more familiar with and that we always urge the community to use, which is through Washington State Department of Health, is the MyIR. And that's directly linked to the state database of immunizations. So someone goes in the Safeway, they get a vaccine, whether it's a flu, a chicken pox, a COVID vaccine, and they input it into their system, which goes into the state database. That is then linked to the MyIR. I will note that there has been difficulties, obviously, with the influx of people getting vaccinated over these last several months. There's just a lot of opportunity for human error, misspelling the name, not putting the birth date in right. So then when someone does look at their MyIR, they can't necessarily pull it up, but they still have their vaccine card. So we have been addressing those questions. We've been urging people to circle back to whoever they got the vaccine from, for that provider to go in, make sure that, okay, yes, this person did get vaccinated on this day, and we misspelled, Nathan instead of an N, it was an E or something like that. And so that we have been addressing those questions. Unfortunately, there's just that opportunity for human error. But there is opportunity for people who are experiencing that to get those corrected.
And if they're using something other than the MyIR app, are these same independent agencies going to these same databases, or is that not how it's working?
I really can't speak to that. I'm not familiar with any of those other programs. I don't know if Lillian is. I'm more familiar with the state's MyIR.
Yeah, there's difficulty because each country essentially is picking their own system to use, and that's not always interoperable with the state system. So there's definitely some lag between all these community systems talking to each other. So that is something that we're hearing from the communication side, but we can definitely look into it to see the information that is available. But just broadly speaking, there's definitely some issues with information exchange, and depending on which platform each country is deciding to go with.
And can each individual citizen, Lillian, look into their own record and see that their information is accurate or correct according to the card that they're holding?
Yes, absolutely. That's the MyIR system for Washington State residents. And again, that just adds to the complications. It depends on which state you're in, right? But for us in Washington State is the MyIR. And when we get that update, I'm happy to put that information in as well. It's currently on our website, but we can put a sheet to just kind of talk about all these different pieces that have been brought up during this discussion.
Thank you.
And if I may, Dr. Atterbury, too, one of the interesting circumstances is that we really moved backwards in terms of technology. When we had to be dosed with the vaccine, you ended up with a paper copy that was very, very critical. The MyIR system, once you're linked, will allow you, if you lose that card, to retrieve another.
And just for reference, really anyone that was born in the 90s, and really any immunization that received from 1990 and on should be listed in MyIR already. It's just something that I think more people are aware of now that with the COVID-19 vaccinations. So we'll be happy to put in a quick summary for the board and for that information.
Lillian, could you also do a quick comparison of what other states have?
Yeah, we can do a quick review to see, just to summarize what the differences are.
Yeah, because I think part of it is that Washington State is one of the few states that has a vaccine mandate. And so we're one of the few states that require people to walk around with proof of vaccination for COVID. So it'd be interesting to see a comparison of what other states are having for folks trying to walk around proving their COVID vaccination to enter places of restaurants and things of that nature.
All right, to clarify, do you mean the different systems for the immunization records or the different vaccine mandates?
Most of this is coming about because people are now, for the first time, having to walk around with proof of immunization on their person, which is something that traditionally hasn't been required of someone to function in their daily business. And so now I think that Washington State, I believe, is one of the few states that's requiring in some areas people to prove that they are vaccinated for COVID in order to enter a restaurant or a theater or a field of play. And so we're on the cutting edge, as it were. So it'd be interesting to see what other states are doing.
Okay, yeah, so we can look at other systems that are being used across other states for that, definitely.
Okay. Any further questions or comments?
Nobody else has anything. I have one more, and it might be for Nathan, or he might defer to Dr. Barg, which is fine. And I'm just curious, but now that we're talking about these boosters, can we get an idea of what fully vaccinated means now that we have boosters that are coming into play?
Okay.
Yeah, I'll send this over to Dr. Barr.
Okay, and he's doing his next, so that's perfect. Thank you, Nathan.
Yeah, I can answer that before we start. So fully vaccinated refers to 2 weeks after receiving the second dose. So for a period of time, at least 6 months, maybe as long as 12 months, you'll remain fully vaccinated. The booster is intended to up what's already there, as in lots of vaccines, immunity wanes over time. So the best approximation is going to be 6 months or more. And it's going to be for people that traditionally don't have the most robust immune response. So myself and several people on the board fall into the greater than 65 age group, as depressing as that might sound. But we do qualify because of our older immune systems for a booster. I've already gotten mine and I'm happy I did. So that answer everyone's question?
Yes, I'm trying to understand, are we going to see a point where, do you believe that in order to be considered fully vaccinated, you will then have to have a booster? And then if the vaccination efficacy wanes over time, are we going to, so this time next year or next spring, are there going to be new requirements to receive a new first and second dose series to be considered fully vaccinated for that calendar year, or exactly how's that going to work?
I think that's all to be determined. They're starting to find out that even though the antibody levels are dropping, there's memory immune cells that react very quickly and may be protective, but this is all under active investigation. And I think we'll just have to wait for the information from long-term studies, like in months of long-term, to know what we need to do next year.
Dr. Barr, I appreciate you bringing up the term long-term studies.
Commissioner McKinney, if your question was more oriented towards like, if someone wants to go to a Seahawks game, do they need to have their booster or not? At this point, counties are just utilizing the, either 2-dose for Pfizer and Moderna or single dose. They have not started going into, is someone 6 months past and got their 3rd dose yet? So they're just looking at those initial series for those type of events.
So that could be forthcoming once they sort it all out.
I cannot say on that.
All right. Any further questions? Thank you all. Dr. Barb.
Well, good morning, everybody. Can I share my screen?
Yes.
So this morning, I want to talk about 3 different things. First, because there's so many terms being thrown around that have to do with epidemiology. I'm going to give you a very short overview of these terms and trying to illustrate what they mean in a hypothetical case. The next thing I want to do is briefly talk about a fantastic article that was published in the New England Journal last week about breakthrough cases. I think it really helps to understand what breakthrough cases are. And then finally, at the end, I'm going to try and clarify the school quarantine rules. So I just need some help trying to share the screen here. Okay, let's see. I'm not seeing that little share screen button, unfortunately.
Okay,
So I'm not getting that little green
you
thing.
actually have to go to Zoom. Go to.
Where did it go?
Probably exit out of that screen, like minimize it.
This was all working before.
Well, of course.
Yeah. Okay, that's not going to work. Okay,
So maybe if you put your mouse down and all your icons should pop up.
yeah,
There we go.
yeah, got it. I'm sorry, my,
Oh, it's okay. So share screen is here.
all right, we're almost there.
And then there's your presentation. Oh, you have to hit share right there.
Got it. Okay, everybody should see the slide. See the
Yes.
little mosquito? Good. Okay. So really quickly, here are the basics of epidemiology, which is really part and parcel what we're all trying to do at the health district. So we ask these questions: what's the problem? And the way we go about answering that is surveillance. So trying to account for all the cases of COVID would be one example. So once you have a problem, you say, what's the cause? So then you go and look at risk factor identification. So risk factor for getting COVID, for instance, might be an exposure. The risk factor for getting severe COVID might be obesity or immunosuppression. Then you look what has worked? What kind of interventions do we need to do to diminish a problem? And then finally, how do you actually do it? How do you implement the things? For example, we find out that COVID is preventable with a vaccine. How do we implement? How do we get the vaccine out to the public? So here's some terms that we've all been using, and I just want to provide some good definitions. So an outbreak is an excess of cases that is more than expected. A cluster is a group of cases at the same place that might be more than expected. So let's say there was 5 or 6 people that had gotten syphilis. And we know that it happened in a particular location in a particular city. Cluster would be the first thing we notice, and then we would continue to study it to see if it's an actual outbreak. Endemic, which is termed for a disease or problem that's present in the population all the time. And a pandemic is a disease that spreads across multiple boundaries. COVID would be a tremendous example. And the a rate of infection, for instance, is the number of cases that occur during a period of time. So I'm going to present this hypothetical case, and the component of this is a potential outbreak at a hospital. And if there was an outbreak at a hospital, you'd be worried. And if it was in total joints, for instance, you might be concerned about having a procedure done at that hospital. So I'm going to start with this quick hypothetical case. An infection control team at a hospital is called by one of the orthopedic surgeons. He's concerned about the increased numbers of infections since the start of the year. According to his count, there are 32 infections during the last 11 months. In the previous year, there were only 17 infections. So the first question is there a problem? Is this a cluster or is this an outbreak? So what do you really want to compare? Do we look at the 17 and the 33, or do we have a better way of looking at it? And the way that this is traditionally done is by rates. So rates are used to compare a disease in 2 different populations. In this case, it would be the year before and the current year. Rates can also be used to compare the occurrence of a disease in a group to historical numbers. So let's say, in this case, orthopedic infections and total joint replacements, again, to historically what's going on at the same hospital and also nationwide. So the way we calculate a rate is probably not unknown to all of you. It's the number of cases over the population at risk times 100 over a specific period of time. So let's see how that works here. There are some other things that would be considered as we're trying to investigate a problem like this. It could be one surgeon's the cause of this, but maybe not. It could be because there's a new bacteria or an old bacteria that has new characteristics, such as new antibiotic resistance or a strain that emerges that have greater virulence. And the COVID is a great example of that. The new COVID strain is much more virulent than the other coronaviruses that have been circulating for decades. Or does something happen in the OR, a new doctor, a new scrub tech? Is there something wrong with the environment? So these are just other things we would consider when we're talking about a cluster or an outbreak. So here's the hypothetical data. We have Surgeon A. He had 3 infections out of 62 procedures for a rate of 5%. Surgeon B did 10 and had 10 infections, 120 procedures, had a rate of 8%. Surgeon C, similar, 6 infections, 103. And Surgeon D, 3 infections, 45 cases. Okay, so that's the data here. Now, when we graph that out, you can see how different the number of cases are of infections, but more importantly, there's a huge amount of increase in the number of procedures. So what's the bottom line? The absolute number of infections has increased, but the number of procedures has also increased. So as we see in the rates here, the rates in the blue, rather in the gray, the rates are very similar, even though these numbers are very different. So the rate calculated from the numbers that we were provided has not increased. So the comparison of rates also show that no specific surgeon is fault because each one of their individual rates was roughly the same. So the rate tells us more than, say, the absolute number. So we don't get fooled by 13 versus 33. There's other things weighed into that. So that's a quick summary of epidemiology. And I'll stop sharing my screen. Oh, I have one more slide to show you. So this is from the King County website, and it shows some interesting rates. And from those rates, they've calculated some interesting data. So the people who are not vaccinated are 7 times more likely to test positive for COVID. And from those people who are not fully vaccinated have 49 times a larger chance of being hospitalized for COVID. And people who are not vaccinated have 32 times the chance of dying from COVID-related illness. So these are all calculated from rates. Okay. So the second thing I'd like to talk about today is breakthrough cases. There was an article published in the New England Journal last week, and it was a longitudinal study done on healthcare workers. And all the healthcare workers in this study were fully vaccinated. There was almost 1,500 that were followed, and they were tested regularly with an RT-PCR test, which you may remember is the PCR test. And of those 1,500, roughly, there were 39 breakthrough cases detected over this study period, which was many weeks. And that gives you a percent of breakthroughs of about 2%. And what they found, an interesting thing is they looked at the antibody titers in both the infected people who are fully vaccinated and the uninfected people who are fully vaccinated. And those antibody titers were lower in the cases that got infected, suggesting that individual responses to the vaccine vary and that it's linked to whether you have a breakthrough case or not. And that would be true in many vaccines and many other diseases. People can get a particular infection and do very poorly because their immune system isn't working that well. So most of the cases in the breakthrough were mild or asymptomatic. And the only thing that might be a little different about this study, it was done during the time when the Alpha variant was predominant as opposed to the Delta variant now. 64% of the cases were in women. And another interesting fact is that the source was often an unvaccinated person. And they pointed out in the article that 2 couples, husband and wife, were breakthrough infected because of an unvaccinated child. So that's one good reason to vaccinate kids. The other reason, of course, is there are kids that die from COVID. There's just not as many as there are in adults. So that's the second thing. The third thing, I want to hope to clarify an issue that really is not the greatest, not the easiest issue to solve, and that's how to keep our kids in school. So the quarantine rules are trying to be as safe as they can, but keep as many kids in the school as possible. So we know that vaccinated people are less likely to get infected. And also they're less likely to have prolonged shedding of a high titer of virus. So the higher titer, the more likely you're infected. So basically the risk of an unvaccinated exposed student of contracting COVID is greater than the vaccinated student. So that may explain or does explain the difference in quarantine rules where one kid would have to go home if he's unvaccinated and the vaccinated kid could stay in school. It's not absolute, it's just relative risk, or another way to look at it is harm reduction. How can we keep as many kids in school but be as safe as we can? And that's my summary of the 3 items, and I'll be happy to answer any questions.
Dr. Bard, could you comment on when it looks like Washington State, or specifically Yakima County, would go from being in a pandemic role to an endemic role? I understand that New York City is talking about an endemic chapter that they're entering into at this point.
It probably, and I'm just taking a guess on this, Dr. Atterbury, it probably would be when the rate more or less flattens out. And hopefully it'll be a lot lower than even it is now, and certainly a lot lower when we've all seen those big peaks in the incidence curves. So when it will happen is, I don't know, but we're on a right trend now. We're going down in deaths, we're going down in total number of cases, and hopefully soon we'll be going down in hospitalization rates as we did last spring.
Any other
That
questions?
last piece up, Dr. Barg, that last graph that you had pulled up, or rather, I think it was a screenshot from.
Yeah, I'll have to share my screen again here. Hang on. You mean the table here? Commissioner McKinney, you mean this table?
Yes, sir. Thank you, Dr. Barg. I just want to, it's sometimes, I like to look at the rough math. So it looks like the deaths for unvaccinated were 51 divided by, it looks like 12,115 positives for unvaccinated. Is that correct?
Which box are you in, Commissioner?
I'm looking at the raw data. So the deaths
Here.
here were 51 out of, over here on the far left, 12,115 positive, unvaccinated positive. Is that correct?
I think so. I think so. I was just actually throwing this up as an example of what you can do with rates.
For sure. And I love the math on this. What's interesting is that if you look at the raw data and you take the deaths, the 51 divided into the 12,115, you come up with a death rate for unvaccinated of 0.4%. And if you take the 20 who perished from COVID that were vaccinated, divided into the 5,437 who were fully vaccinated and tested positive, the death rate is 0.3%. So I think that the raw data is interesting. And let's just look at the hospitalizations here real quick. So we take 541. So hospitalization rate, oh, that doesn't seem right.
While you're working on that, we just say that in a small area, like say the city of Yakima, there's not a huge difference, even though, like, say, unvaccinated have twice the death rate. But when you multiply that by a country, you could be talking about several 100,000 people out of the population of the United States.
Sure, I'm glad you brought that up. I looked at King County this morning just because I wondered the same thing, and they have a much larger population. And of course, they have a much larger vaccine saturation for population. Their death rate for unvaccinated is 0.81 and vaccinated is 0.65. And this is comparing the last 30 days. So they're a much larger percentage of vaccinated people and a much larger pool of people to pull from and compare the data. So they do seem to be currently having a higher death rate for the vaccinated, even unvaccinated in Yakima County. So it's a good point that you bring up, that you do need to look at different places. But I do appreciate that you brought up this data so we could look at it.
I think you're not looking at that correctly. So when you look at the 20 deaths of those that are fully vaccinated, you're comparing 51 to the 12,115 people, you really need to take how many total people had COVID, vaccinated or not, and then how many died within those groups. And you'll find that it's actually, well, it shows here 72% were not fully vaccinated. So your rate's going to be different. You can't really compare the 20 deaths to the 5,437 fully vaccinated. The comparison's not the same, I guess.
Well, no, I agree with you, Melissa, but it's still interesting to look at how many people who were positive for COVID and then were hospitalized and then actually perished from COVID that were vaccinated versus the same progress for someone who is unvaccinated. Anyway, it's interesting.
Any
Okay.
other questions? Melissa, did you have something to say regarding the rates?
No.
All right, are we ready to move on? Let's move to Melissa and her report.
Good morning, thank you. I'll start off with our TB. We had a new TB patient in the last month who is, it's involving a very large contact investigation. So our nurses are working on that with Indian Health Services on a large contact investigation. So that brings our total cases of TB, active TB, to 7 so far this year. We had 2 cases total last year. Our average is usually between 10 and 12. So we are definitely seeing an increase this year. And I think that has partly to do with misdiagnosis or underdiagnosed because of COVID and lack of care, COVID being on the front, that people aren't getting the care that they normally would have. For flu, we're seeing low activity across the state, as well as in Yakima. We have had on our surveillance several flu cases reported, including influenza type A and B, but the activity is still very low, but we'll continue to watch that. We're seeing an increase in our syphilis cases, including congenital syphilis, which is when a mother has syphilis while she's pregnant, and that transmits to the baby and can cause complications, including death of that fetus. Most of these cases are linked to our homeless and IV drug use population. So Dr. Barg has been working a lot with our DOH staff who monitors those cases and does contact investigations for those. As far as COVID, our hospitalizations, we're still seeing a lot of, when we get the reports daily, our hospitalizations for staffing are still at red for all 3 hospitals. They're all having staffing shortages still. And our outbreaks are, we have seeing a lot of outbreaks in our long-term care facilities, which takes me back to the beginning of when this pandemic happened, and that's where we were seeing our cases. So not seeing so much deaths out of those, but just a lot of outbreaks within the long-term cares. And one of those being Sunnyside Assisted Living Facility, which has been in the media for their outbreak. They have, I believe we're now at 35 of their 45 residents that are positive for COVID. So that outbreak is quite large. Most of those, we did pull the data, most of those individuals are fully vaccinated back early in the year when the vaccine first came out. So it does show the need for those boosters in that community. But we've not seen any deaths out of that outbreak. So we're fortunate on that. So we're working with the Department of Health. We actually are doing 2 site visits today at long-term care facilities that are in outbreaks with a nurse consultant from the Department of Health to go in and offer some infection prevention guidance, just make sure that they have all the PPE they need, that they're using it appropriately, and help try to contain their outbreaks that are going on. And that's all for me, unless anyone has questions.
Melissa, on your 7 TB cases, are any of them related to one another, or are they individual cases unrelated to one another? And are any of them multi-drug resistant TB?
None of them are multi-drug resistant. There are 2 that are related, household contacts, but the other 5 are all independent.
Any other questions?
This is Dr. Claire. I have another question for you, Melissa. I appreciate the data recently that included the information on deaths due to COVID, whether they were vaccinated or unvaccinated. But I think as we talk about whether we need boosters and whether there's a waning immunity, it'd be nice to see that show a trend. And if there are enough cases, start to report that on a month-to-month basis as well, so we can see if there's an increase in deaths among the vaccinated who have not received a booster.
they're looking at more deaths that those were vaccinated greater than 6 months ago.
Correct. So right now, the data is just presented in a group from April 1st to the current date. But the other data in hospitalizations and cases is being done on a month-to-month basis. And even though the totals are the only ones that are getting the percentage, we can at least look at the raw numbers month to month of number of deaths, whether those were in vaccinated or unvaccinated, and just kind of compare the numbers.
Okay.
And then another question, how are we doing in terms of the vaccination of workers in these long-term care units?
They had their deadline of October 18th. They're all having some staffing shortages, which is a problem. Some people have quit. But what we're seeing now is what they're doing is they're sharing staff, which is another concern. So when they don't have enough staff, especially with physical therapists, they're going from facility to facility, which is how our outbreak started last year in the long-term care facilities. So I can't tell you exactly how many, but I know that in the beginning, when the mandate was first out, that they were some of our lower vaccinated groups was the long-term care facilities for staff.
Melissa, in the long-term care facility that you mentioned with the 35 positive cases, was there any changes in their protocol or their staffing ratios, or have you guys gotten any data onto why there's that outbreak?
What they're finding is that they were doing communal dining because this is assisted living. They all have their kind of independent where they have their own rooms. And so the common thing that they found was the communal dining. So obviously that has completely stopped. You know, they do have positive cases in their staff, but not like they do their residents. So it's likely that it was just from the communal dining that they were doing.
And to bring up Dr. Barg's point, this is a group of people that potentially could have had their immunology wane over time because they're high risk.
Yeah. Yeah, these folks were vaccinated in February, March, and April. So definitely past that 6-month time frame where we show that waning of the vaccine. So.
All right. Any further questions for Melissa? All right, hearing none, we'll move on to Sean.
Good morning, everybody. I'll keep my report fairly brief as I don't have much to update on COVID. Really right now it's for myself, it's communicating with any events, bazaars, things like that, that are reaching out with questions about how to promote and hold an event safely. Of course, indoor bazaars are requiring masks regardless of vaccination status as per state mandate. We're also getting some questions about trick-or-treating and how to safely conduct that. So we're providing that education and outreach to the community. I believe we've done some Halloween education, trick-or-treating education via social media and media releases. So just giving everybody the information they need to stay safe over the Halloween holiday. And you know, a lot of the very popular bazaar events that happen this time of year as we approach Thanksgiving and Christmas. So we continue to work on that and provide that education to the community. For environmental health, we are approaching the end of our busy season, which for land development, which usually starts to taper off when the weather turns less favorable. We're still getting quite a bit of work coming in the land development program, but we should start to see a downtick in that soon, which will be helpful as we have newer staff coming on. They need to get trained, which will start training. Training begins in the food program because that's our every day of the year program. It's by far our biggest one. So that's where Stephen's focusing his attention. And we have another new environmental health specialist starting on Monday, November 1st. So we'll be working hard getting the newer folks trained up in food, and then as opportunities present themselves in land development and drinking water will expand their knowledge and expertise in those programs. That's really all I have for today, unless anybody has any questions. Happy to answer those.
Sean, I've installed a hot dog cannon in my front yard so that I can help social distancing for the distribution of candy. See my design, please let me know.
I might have to check that out. That sounds like a lot of fun. I know my oldest boy would really enjoy something like that.
we have to regulate whether it's bunned or unbunned. These are important questions.
Okay, any other comments or questions for Sean? All right, we'll move on to Lillian Bravo then.
Thank you. So as I mentioned, a few updates from my update last month. I had talked about some of the immunization clinics that are taking place. So again, as a reminder, most of those will actually be taking place over the next week. So I'm not sure if you all were able to see, but we did send a media advisory about it. It's on our website, and of course, we'll be advertising on social media. So just a reminder, of course, since we had the schools that were not in person last year, a lot of families actually got behind on their routine immunization. So we wanted to make sure that in these outreach efforts, we included routine immunizations since it's flu season, that we offered the flu vaccine, and of course, for any families that that have eligible children that want to get the COVID-19 vaccine, that they have that opportunity as well. So a few of those taking place will be at West Valley Junior High, at the community-based organization Nuestra Casa in Sunnyside, Highland High School, Student Family Center here in Yakima, and several others. So again, we're happy that we've been able to partner with not only our COVID-19 immunization team, but also some other clinics like Swafford and Halma, Yakima Valley Farm Workers Clinic, and Yakima Neighborhood Health Services to be able to provide these opportunities for families to really get all these different services in one spot and make it more convenient for them. And so as we have more of those available, that'll be updated on our website. Another follow-up, last month, I also talked about how through the Developmental Disabilities Program, one of our employment agencies did have to stop offering one service, that left about 30 individuals who needed to find new services. I'm happy to report that all 30 did actually get new services with other employment providers. So that's a huge success for us because that's what we want to see. We want to make sure that people stay in services and they don't lose services because it's no longer being offered. So good success for our developmental disabilities program in that sense. And then October is Developmental Disability Awareness Month. So we did launch a campaign called the See Abilities campaign. And I can send that in an update as well. And actually, I'll put Jocelyn, I don't know if you have the time to be able to pull it up real quick, the seeabilities.org. Essentially what that campaign is meant to do is just raise awareness about our different community members with developmental disabilities. The campaign focuses on 4 individuals that are part of the employment program through DD and kind of spotlights them as they're working throughout the community. It's been received very positively. The people that were selected are very well known. Everywhere where there's an opportunity for people to comment, like on social media, they're saying, hi, Peter, it's great to see you. I know him. He's always so nice. Israel, when he bags my groceries over at Sunnyside at Safeway. So it's a really positive campaign. It's been really great to be able to see it received so well in our community. And again, the point is really just to raise awareness and to make sure that we can be inclusive of all members of our community, including those with developmental disabilities. So it was a great campaign, something different to do. And I think everyone really enjoyed working in it. And
if I may add something, Lillian, if you don't mind.
Yes.
This continues to be a partnership, the Developmental Disabilities Program with the county. And we're really privileged to be able to support the program because it really is about inclusion and pride in all of our residents. And it's something that we've invested a great deal of time in. It's also pleasing for me that we are able to roll out a campaign that's this important in the middle of the pandemic. Thank you.
Yes, thank you. It's again, welcome by absolutely everyone that's been working on it and everyone that's been seeing it. I think it's been really nice to be able to continue to move forward with other pieces of our work as well. And then finally, just around communication. So again, as we've been mentioning, it's flu season. So we're wanting to make sure that people are aware, that people know where to get their flu vaccine, as I mentioned with these education events. And of course, with every winter, the same as last fall and winter, we have guidance for individuals just about what different activities are recommended based on each individual's choices on what they want to do. So of course, we're not telling people not to do certain things, but just putting information out there so that people can make their own choice about what they would like to do in regards to trick-or-treating, gatherings, really many different activities. So again, just putting out lots of information so that people can make their own educated decision on what they'd like to do. And all of that information is, again, released through media releases and through our website. Are there any questions? Thank you.
Thank you, Lillian. Next, we'll move on to unfinished business. We have 2 items. The first one will be a process of scheduling Board of Health special meetings with Andre.
Thank you, Mr. Chair. And I'd also like to add that there is one component of new business that I'd like to add in a thank you. I don't know if you'd like me to deal with it at the end of the meeting, but I'd like your consideration if you don't mind. So the unfinished business is scheduling Board of Health meetings. There's 2 pieces of this that I'd like to tackle if you don't mind. We have heard from some board members who are unable to meet on the Wednesday that we normally have the special board meeting in the evening. And so I'd like to ask for your consideration that we move to a different day for those evening meetings. That's important that we have representation from our board, and that's something that I'd like to ask your consideration on. We can talk about the specific days if you'd like, or I can go into the other component of the question of scheduling, which is what we do over the next few months. Would you like to tackle the issue of the days first?
Yes.
Okay, so Wednesdays is not working for everyone in the evenings. We continue to have 5:30 to 8:30 as our normally scheduled time. We can conclude early if there is board business that has been completed. But I'd like to consider that we maybe look at either a Tuesday or a Thursday as opposed to that Wednesday, so that we can ensure that we have coverage.
Andre, I'd just like to say if it's with regard to my conflict, it's not the day, it's the time. So Wednesday at another time would work, but I have an evening conflict on second and fourth Wednesdays for the month.
And Commissioner Lindy, did you have a perspective?
I was just going to say, if we were going to have it during the second week of the month, the Tuesday would not work, but a Thursday could work for me.
I would suggest that maybe let's have a survey of Tuesday and Thursdays.
Okay.
Can that be sent out, and then that information can be sent back to you, Andre, rather than going back and forth on calendars here?
Yes, good point, sir. Thank you. And also, to be fair, that's one of the reasons why we wanted to have an evening meeting, was that some of our members work during the day and can't schedule additional time. So we will do that. Thank you. We will send out a poll and we will make a determination.
So Andre, I would appreciate if you consider that poll doing a second Wednesday morning rather than an evening time. Tuesdays will always be ruled out for me. Wednesday happen to work well. If it doesn't for everybody else, can we just look at, we're doing Wednesday mornings and everybody appears to be here. If we have a second meeting, if we could just do another Wednesday morning?
I think that part of the reason why we did move to an evening is because it isn't actually convenient for everyone to do it during the workday. So I would like to keep it as an evening option.
Yeah. Well, let's.
I agree. And then, so another thing I heard that Dr. Cleary said is that he said the second and fourth Wednesday. I know that we usually meet on the third Wednesday, but I'm also available in the evenings on the first Wednesday of every month. So if Wednesdays are working for us, I'm always available in the evenings. And, you know, for me, Mondays are always ruled out, but I don't think I'm hearing that is being proposed right now.
Well, thank you, Ms. Duval. And yes, we'll attempt to clarify so it's as simple as possible, so it is not confusing. One of the reasons that we didn't attempt to have them early is that we always have our normally scheduled meetings the last Wednesday of the month, so we were not trying to have a meeting that was almost back to back in terms of 1 week the next week. But we will certainly send that out through Victoria to you, and appreciate your consideration.
So thank you, Mr. Wall, because Wednesday evening is always the best option for me. And so I'd be willing to do another Wednesday evening. Thanks.
Very good. Thank you. Are there other perspectives to share? Okay, thank you. Moving on to the second was that we had discussed, for the purpose of clarity with the board, the interest in perhaps looking at our normal scheduled meetings to discuss the interest in and possibility of the next special meeting. I believe that's what we had discussed. And so what we wanted to consider was whether the board wishes, as an example, to have a special meeting in November. So we could have that conversation. I would like to share, for the purposes of clarity, that we normally don't have a scheduled regular board meeting in November because it often conflicts with the holiday season at the end of the month. So normally we would not have a November board meeting. We have a shortened meeting in December, or I should say closer to the beginning of the month on December 1st, because again, there have historically been concerns about conflicting with time off. So currently, we are not scheduled for a board meeting in November. I'd like to gauge the board's position on that and whether the board is interested in having a meeting, which we could call a special meeting in November, perhaps in the first 2 weeks of the month.
Andre, can we make that decision based upon any agenda items that are submitted beforehand?
Certainly. And
so perhaps if we polled the week before, if there were items that were important, then we could make a decision on whether we should have a meeting or not.
Yes, sir. And Commissioner McKinney, did you have a perspective?
Yes, I was just going to say absolutely. I think that, again, we've got, as you just have stated earlier in the meeting, potential emergency approval for children, for boosters. We have ongoing mandates coming down from our governor for our workforce. How does that impact school sports? We're heading into another school sports season that is, I believe, considered to be different than the fall sports. Some of the winter sports are higher contact. You just stated previously that we're heading into flu season. I can think of a myriad of reasons why it is important for us to have a meeting in November.
Okay. So we'll work on getting a time in November out, considering the potential conflicts in a poll to the board. Looking hopefully for the second week in November. That's what we would look for, although I believe there may have been conflicts for the board members, so it might have to be the third week in November. We're trying to avoid certainly bumping up against holidays.
Andre, maybe I'll defer this to the chair, but do we have a consensus among the board? I haven't heard from the other board members.
I'd like clarification on if we're talking about the regular board meeting on a Wednesday morning, or if we're talking about a second meeting during the month. I'm confused about that at this point.
Yes, let me clarify. Thank you, Mayor. We currently do not have a regular board meeting scheduled in the month of November. We don't cancel our regular board meeting. So if this were any other month, we would have a regular board meeting. So as an example, December 1st is our regular board meeting in December. It's just much earlier because of the holidays. And so we do not currently have a regular scheduled board meeting in November.
Thank you.
Dr. Cleary asked for consensus from the board on whether we should have a November meeting, and I defer to the chair and vice chair on how to proceed on that.
Don't we already have consensus? We've already agreed in previous meetings that we're going to have a special meeting every month as long as we're in an emergency order. So really what we're talking about is whether or not we want to stop having our already approved special meeting that this board has determined it would like to have as long as we're under this emergency order.
And just to clarify, Andre, you're not referring to the special meeting for Thanksgiving. You're referring to the regular scheduled meeting that would be the fourth week, correct?
Well, no, currently we do not have the scheduled meeting. We haven't had scheduled meetings in November in many years. And so
right, that's because it falls the day before Thanksgiving.
Correct. And so if I understand Dr. Cleary's point was that we could schedule a board meeting, a special board meeting in early November. And if there were no agenda items added, then we wouldn't need to have it. But of course, to Commissioner McKinney's point, we have agreed as a board to have regular board meetings, or rather special board meetings throughout the pandemic.
Yes, and I guess I would add that it appears that there are a lot of potentially impending items that could be on the agenda. So it seems at this point, at least until we decide otherwise, to put something on the agenda as a special meeting, or continue to leave it there, I guess I should say.
Okay, so it appears we have some consensus. We can work on the times and the dates, and then we'll send that out to the board for your agreement, and then we will schedule a special board meeting in early November.
So Andre, let me be clear then, our regular meeting in November will not be on the third Wednesday, but it may be on the second Wednesday, the regular morning meeting, is that correct?
I'm so sorry, it's very confusing. We do not have a normally scheduled regular board meeting. We're looking to have a special board meeting.
Okay, got it, thank you.
And
Dr. Thury had suggested another Wednesday morning earlier in the month, which I would be in favor of, but that's okay.
And the other issue, again, will come up in December. We have a December 1st scheduled board meeting. It's a regular board meeting. It's just at a different day of the month. We would anticipate not wanting to have a special board meeting later in the month because of conflicts with people's vacations. If the board wishes to have a special board meeting, we certainly can. But I do want to share with you that November and December are specifically complicated because of traditional travel and family relationships.
Okay. So we have on the packet, the front page of the packet is November 10 for the special evening meeting.
Yes, it's just that we continue to have conflicts on that Wednesday evening.
So on the survey, we will determine that date or that time.
Yes, sir.
Okay.
Okay. I hope I haven't thoroughly confused everyone. And we will attempt to send that out and look for your perspective.
Okay.
A quick question, Andre, just slightly off the topic, but as we look at these November, December meetings, do we have any board members that are slated or to have their term being concluded at the end of the year? I know we've got 1152 changes that'll be coming in the year to come, but we're not there yet. So are there any appointments that are coming to an end at the end of this year?
I don't believe so.
Okay.
Ryan, we've checked on that. Victoria, we can send that out so that everyone can see. Victoria, if you'd like to share.
Yeah, we don't have any ending this year, but I'll send out the information I have after the meeting.
Thank you.
Sounds good.
Good question.
Thank you.
Any further comments? Okay, we'll move on then to Mr. Elliott and a review of the RCWs.
Good morning, everybody. Hear me okay?
Yep.
So I had asked Victoria to send out a packet of information to all of you in advance of the meeting. It starts, I believe, at page 28. And before I get into sort of these details, I want to jump back. Dr. Atterbury asked me a question at the last board meeting about sort of how the exemptions go. And I told him, I said, well, go back and watch the board meeting from the end of September. Well, that was good advice to give you 2 weeks ago. But I will tell you that as of yesterday, there have been some more changes. So I will start, I guess, by saying that the EEOC has changed guidance related to religious exemptions for the vaccine mandates. This is not part of your board packet because it literally happened yesterday. So I am trying my best to keep as up to date for this board as I can. My intention will be after this meeting, I will send to Victoria so she can send to each of you the link to the EEOC new guidance related to religious exemptions for vaccine mandates. And obviously, to the extent that after you review it and you have any questions for me, I will be happy to answer those. But I thought it'd be too much to pour this on Victoria this morning and try and go through it considering all that we have.
James, pardon me, if you don't mind, Jocelyn, do you mind expanding the screen, please? Thank you so much. Pardon me, James.
No, it's okay. So I will send that out to Victoria to disseminate to all of you after this is over, so that for you who have been asked the questions, and I know a couple of you have, related to what the exemptions are potentially for mandates, especially now on the new, what I would call the federal level of these mandates. It will be an opportunity for you to share that with those people who have asked you those questions. And I'll be happy to, after you've reviewed it, if you want to contact me, I will try and explain them as best I can. I will tell you to read them because I was actually shocked. There have been some pretty large size changes that have been done on this. So I will let you review that on your own. Now getting to the packet that I had sent, sort of the question that I got asked was related to the idea of vaccine mandates sort of on the RCW level, the statewide level. There are also those issues on the federal level. I want to spend most of my time on the state level if I can. That's why I sent you everything that would sort of give you a nutshell on the statewide. There is a lot to cover on this topic. I am versed on the federal side to the extent that I can answer those questions if there are specific ones. My goal in doing this was to try and give an understanding to this board about where the powers, the duties come related to rules, et cetera, that would deal with vaccinations. I know part of the question is trying to figure out where does the authority come from, who has it. I had laid out for you in this packet, and I'm glad to see it's up now on the board. This is page 28 of your packets if you're having trouble reading it. My goal was to try and highlight certain sections so you could sort of see the overall powers that are in play and how the situation works. So I had laid this out, and it looks as though we've got it laid out here. This is page 28 of your packet. It sort of lays out where the powers and duties of the Board of Health come from, which is one of the players related to drafting of any vaccination rules. There's statutory authority given to the Board of Health. There is also statutory authority given to the Secretary of Health, which I think is the next page, if I remember right. Sorry, I got to go through my packet here, see how it got put together. The Secretary of Health also maintains similar powers. Oh, did this not make it in here? I apologize. I thought there was more in here. Oh, okay. All right. I moved on. Again, and I'm sorry for making you move the pages around. This 4320, which starts on page 28, sort of gives the Board of Health powers and duties. I didn't include the section related to the Secretary of Health, who also has similar types of rulemaking authority. The basic gist is this, that the legislature has created in the Board of Health the ability to adopt rules related to certain areas. Section F, you see down below, adopt rules, prevention and control of infectious and non-infectious diseases. This statute, 4320.050 subsection 5, gives the Department of Health the ability to draft rules that would relate to requirements for infectious and non-infectious diseases and the control thereof. So the idea is legislature gives the Department of Health the ability to draft rules. The legislature is also given the Secretary of Health and the Board of Health essentially the same power and authority to delegate and adopt rulemaking authority. You can see that identified in subsection 4 down below, that the state Board of Health may delegate any of its rule adopting authority to the Secretary. So just giving you the overall picture, Board of Health, Department of Health, Secretary of Health have rulemaking authority in terms of what they can and can't do related to this issue of control of infectious and non-infectious diseases. This is sort of the starting point because it shows you they have the authority to do it. Then after you consider that concept, and these are, I put them poorly in order when I sent them, and I apologize. You can go to page 31 of the packet. Skip that. Yeah, skip page 30. We'll come back to it. Whoop, go back up. Page 31 identifies what are called the Washington Administrative Code. These are the rules, guidelines, et cetera, that govern areas related to the Department of Health. This is Title 246 of the Washington Administrative Code. I've only given you just the first page because it deals with the specifics down at the bottom of communicable diseases. It identifies some of the sections that are there. So again, our starting point, statutory authority given to Board of Health, Department of Health, Secretary of Health. The Department of Health, the Board of Health can draft these rules or regulations that would then fit in this Title 246 of the Washington Administrative Code under the Department of Health. I've highlighted down in the bottom, you'll see section 100, 105, and 110. There's a lot more blacks than what I identified here. This is the gist as it relates to communicable diseases starting in 100. There are others rules that are related to the Department of Health under different areas, such as requirements for hospitals or living care facilities or et cetera. I didn't want to make this too big and get into too many different areas, but there are requirements under those organizations for them to draft their own types of immunization programs and sort of to prevent certain types of diseases, et cetera. I didn't want to go into those details because my guess is this board probably has a greater interest related to the school side and the potential vaccinations there. That's kind of where I focused as we move forward in some of these additional sections. If you can scroll back one page, I'm sorry for this, which would be page 30 of your packet. You can see, go a little bit higher if you can to the starting point. You can see under the statutory authority, which is RCW 28A, it identifies the Board of Health's ability to adopt rules related to immunization programs. So 28A.210 is an area that, to the extent anyone has questions related to school immunization programs, this is sort of your starting point. This is where the authority comes from. It identifies the purpose and sort of the overall authority and background for it. I did not give you all the pages related to RCW 28A.210 that would be how the immunization programs are supposed to work, what the exemptions are, exceptions, et cetera. I have all those here on my desk in case anyone wants to walk through any of those. The idea here was to give you the picture that this authority related to immunizations for schools can be found under this RCW. So I know that I probably just jammed a whole bunch of sort of laws and wax down on you fairly quickly, but I want to stop right here and ask, does anyone have any questions about how, sort of where we are or what I've identified to this point?
I have one question, Mr. Elliott, under, I'm just reading at the very bottom where it says immunization program purpose, and it says, providing a means for the eventual achievement of, quote, full immunization of school-aged children against certain vaccine preventable diseases.
Yeah.
So full immunization.
So this is not a brand new statute, Commissioner. 28A.210.060 has been on the books. The most recent alteration to it was in 1990. As you'll see underneath it, there's a parenthetical. It says 1990, Chapter 33. This is how the language has been used for the statute since 1990. So this is not a new change. And if anyone took anything that I showed you thus far to be new information, it's not. Most of this information has been on the books for years. This is the way the statute identifies the purpose related to the immunization program, and it uses that language, full immunization. That was The purpose, essentially, if you go through the different WACs or the RCWs, it deals with the types of diseases that were identified. It actually gives a list. I mean, it's tuberculosis, it's polio. I mean, there's a list of the ones with the full achievement sort of immunization for school-age children. That's how it's written. So does that help, Commissioner?
Yes, sir.
Okay. Dr. Cleary, I see you took it off mute. Did you have a question?
Yeah, two questions. One is, are there any changes recently in the COVID era to these RCWs? And the second is, have there been any successful challenges of the authority of the Secretary or State Department of Health regarding vaccinations?
So on two areas, as it relates to 28A 210, which Dr. Cleary is again just focused on for schools, the immunization program, on those RCWs, I was not able to find any changes that have happened those yet, and I'll explain that in a second, but there's been nothing that's been changed on that. If you're talking about changes related to not RCWs, but Washington Administrative Code, and again, we have to keep in mind the distinction between the two. The RCWs are the statutes that create the authority, lay out the power essentially for different organizations to operate. The Washington Administrative Code then is the rules or guidance that's been created by certain agencies. There have been lots of changes in Washington administrative codes over the last several year and a half. There have not yet been any that have been done related to vaccinations specifically. And as we'll go through this presentation a little bit more, I wanted you to get the understanding about how, if there was going to be a change for the Washington Administrative Code, those rules related to immunizations for school-age children, you could actually see the process. And we'll look through some of those in terms of presentation that follows. So I can get into that. That's question number one you had. Question number two, as far as successful challenges. So I've tried to keep as track as I could just in our state. I know the Honorable Federal District Court Judge Thomas Rice had a recent ruling within the last 4 days or so related to a challenge that was brought, I think, by troopers. It may have been healthcare workers, and the Honorable Judge Rice upheld the power of the governor to issue the mandate related to that. I don't have the case in front of me, but I know it came down literally in the last 4 or 5 days or so. I know there have been other challenges on the other side of the state related to some of these questions. I have seen none that have overturned any of these powers related to issuing the mandates, et cetera, in terms of their operation. So on a state level, and I'm going to focus there, Dr. Cleary, unless you want me to expand on the federal side, which I know there are some challenges there. But on the state side, I have seen zero that have effectively challenged or overturned. But keep in mind one thing, again, those were being brought on what I call an injunction basis. So the purpose of them was to enjoin the rule from going into effect so that it could not have that effect on employees as of what would have been October 18th. So they were on that injunction basis, and they were denied. And I know the Honorable Judge Rice wrote an opinion on one in the last couple of days, which covers the Eastern District of Washington where we are. So does that help, Dr. Cleary?
Yes, thank you.
Okay, Commissioner McKinney.
Real quickly, so just to clarify, our RCWs come from our legislators who are elected, and the WACs are written by people who work inside of the agencies, unelecteds.
So the RCWs, yes, those are statutory creations that are done by and through the legislator through the formal legislative process. Where agencies, and I'm sticking with the Board of Health here because the Department of Labor is another one that I know has had some rules or guidelines related to this area, and I can cover that in a minute. But it's the Board of Health issuing rules or guidance under their statutory authority to give rules or guidance to the people related to certain areas of the law. So it is, to answer your question, the Department of Health, the Board of Health, the Secretary of Health, those are not elected individuals. Those are ones that have been given this power and authority by and through the legislature, as we looked at on that last statute. Does that help, Commissioner? Was that a yes? Okay, all right. Okay, in terms of where we're at right now, does anyone else have any questions? All right, if you can change to the next screen, please. What would be, actually, I need you at number 32. Keep going. Okay, 32. So I wanted all of you to see a couple of things, because I know that the question that is coming out right now, I know a area of concern that has been voiced is related to sort of changing of immunization related to school children. On October 13th, the Washington State Board of Health had gone through a briefing related to the breakdown of the immunization criteria. I have given this to all of you with the intention that I could never explain all of this in this process in less than 20 minutes. So my hope was to get it to all of you, that you could take a look at it and that you could see how this process goes. You could see the exemptions. You can see normally how the framework goes related to creating an immunization for school-age children. You can see essentially there is a nice layout. Oh man, I'm sorry. Should have tabbed this one so you knew what page we were on. Could you go to page 37 on this? So page 37 identifies this is the board's process. And I appreciated the person who put this presentation together. I did not watch it. I just found it after you all asked me to do this last week. So I thought it made most sense so that you can see this board process about how things went, with the understanding that each of these pieces sort of lays out the process that the Board of Health would go through before implementing a new rule change to the requirements under WAC 246-105, which is the immunization schedule. This is the process that the Board of Health has identified as their normal process of going through this. If anyone has any questions for me on this, rather than me trying to explain it, I'm happy the best I can, or hear any comments on it. If anyone has anything. All right. On here, you will also...
James, if I may.
I'm sorry, go ahead.
No, thank you. I think that you're doing a great job of explaining it, but I did want to reiterate what you said previously, which is this is not a new process. This is the normal process for the inclusion of any major change to anything related to immunization. Thank you.
Yeah, that is correct. This is what they have identified as their Board of Health process for adopting new rules, specifically on the targeted area of 246-105 for vaccinations. I have reviewed the statutes, and this is consistent with what their requirements and their authority is. I will point you to the third box, which in order has at the bottom of it that it's a group may be identified, convened as a tag group to assess the antigen against the 9 criteria. And that will be then our next set of slides. I wanted to get that to you as well. If you can scroll forward, please, to, let's see, our next group here is, I think it's page 44. Let's see. I'm sorry, starting in 43. And then moving forward to 44, I've given you the packet that is the Immunization Advisory Committee's criteria for reviewing for potential inclusion in 246-105. This breakdown identifies for you then the 9 criteria that we just referenced a set ago, and it sort of walks you through it. It's those 9 criteria are found within this document. And it sort of lays out the explanation for the criteria, how it goes, the process, et cetera, et cetera. So my thought process here was you could see the overall process of how the Board of Health would go through this normal immunization change process. You could look through this section, which covers the 9 criteria that they would go through. And you could evaluate them on your own and sort of look at what it was and get an explanation directly from them. So I figured getting you all this information and letting you review it, which I know you all did over the weekend when you were really sort of lacking on sleep and you wanted to make sure to study all this stuff. But I think it's important for not only you, but for anybody who's trying to understand how these changes happen, what the Board of Health has to go through, that criteria that have to be considered, and then the overall process of what normally takes place. So before I move past the Board of Health sort of process, 9 criteria, anybody have any questions on those areas? All right.
Focused on the children, the aspects of children, Mr. Elliott, and is it because, are there any RCWs that are laid out that require vaccination of adults?
So in our state, there are no other RCWs that lay out requirements in these areas. And again, keep in mind, Commissioner, that to the extent that there would be any rules related to this, they would normally be found in the Washington Administrative Code. So RCWs and statutes, I'd say no. Washington Administrative Code, though, under the Department of Health, which was that section that I had, 246, I had a layout of sort of a breakdown of what chapter 46 of the Washington Administrative Code was just the beginning. It was that first page. If you go through the Washington Administrative Code, there are some other areas in which the Department of Health has issued requirements on certain types of health-related facilities in terms of how they handle what I would consider to be infection control programs. So, for example, I know for ambulatory surgical facilities, I know for hospitals, I know for in-home service agencies. If you look at 246, the Washington Administrative Code, there are some sections in here that identify a requirement upon certain organizations to take certain steps. And I'll give you an example. Now, I didn't include this in the packet, but I will tell you. So under WAC 246-320-176, this is relating to hospitals. So WAC 246-320 identifies the overall Department of Health rules and guidelines for hospitals. Specifically, WAC 246-320-176 talks about the requirements for an infection control program developed by hospitals. So it says essentially hospitals must develop, implement, and maintain a written infection control and surveillance program, followed up by developing one that's consistent with CDC and other nationally recognized professional body organizations. So not a statute, a Washington Administrative Code, previously identified by the Department of Health as an important rule or guideline. This one's about hospitals. There are others in other areas such as in-home service agencies, ambulatory surgical facilities. It puts the requirement on these organizations to create their own written infection control and surveillance program. Now, does it say in there that they have to have certain vaccinations? No, the requirement is on these organizations to prepare their own infection control programs. And then it's essentially on those hospitals or other organizations to create those related to their employees. Councilwoman Duvall, are you waving your hand? Oh, okay, I'm sorry. So the idea here, Commissioner, is that the WACs do provide for requirements on some, and I'm focused on the healthcare because that was really the only area that I could find them, is a requirement to implement an infection control program. And it doesn't go to the extent of telling hospitals what vaccinations they have to have for their workers. It just puts that onus on them to create a program that's consistent with CDC recommendations. So does that make sense, Commissioner?
It does, thank you.
So I will say that as these go along, each of these organizations, and I'll give you a hospital for an example. So for hospitals, oftentimes they will have, in fact, I can't think of a scenario in which there's a hospital without union employees, and Commissioner Lindy can help me with this as he's maybe dealt with some of these. Hospitals will have workers who are actually union members who will be working for them. I can't remember if it's Local 17. I can't remember the nurses unions. I can't remember all their numbers. But for those organizations, like a hospital where they have a union, they will have a collective bargaining agreement that sort of guides their operations. And sometimes in collective bargaining agreements, an employer, such as a hospital, will include vaccination requirements as part of the collective bargaining agreement. I know that in certain employers, they have laid out vaccination requirements. I know that sometimes there's requirements related to flu vaccines or others for certain healthcare organizations. But those are, again, keep in mind, the hospital, which has been given the requirement to create an infection control program, chooses then in their negotiations through the collective bargaining agreement to require certain vaccinations on their employees. So I'm going to go ahead, Commissioner.
Yeah, if I could interject, yeah, I mean, I can't speak for every hospital in the county, but I think they all have some level of union representation. And frankly, there was an immunization requirement at my the hospital I worked at, and what they did was they based their immunization requirements on the CDC recommendations, and that would apply to union and non-union employees, and clinical and non-clinical employees alike.
So, overall picture, you have seen, and I focused on the main area where there is statutory requirements and also WACs that are specific to vaccination requirements. It's really based on the school area, or in these areas that we just covered under the Washington Administrative Code for healthcare facilities, hospitals, in-service, ambulatory surgical centers, et cetera. That's really the targeted area. I was not able to find anything else in our state. I don't think that there is. I think that's sort of the major focused area. So any questions on this as we've gone through it? All right, so to help then understand where we left the Board of Health on their last step of the process, it was the requirement then that there would be a rulemaking process. And I wanted to get everyone an understanding related to how the rulemaking process, which is by definition, how the WAC 246 would be created. So in simple terms, once the steps have been met by the Board of Health and they get to the end and they figure they want to make a change to the immunization program, under normal scenario, there would be a rulemaking process that would take place in order to do that. The rulemaking process is guided by what's called the Washington Administrative Procedures Act. It is RCW 3405. And I wanted to give you in your packet, which is starting on page 49. And I'm sorry for, once again, moving around so much. But again, the goal was to try and get you all the information and allow you to ask me whatever questions you want. Perfect. Going right there. I pulled this off the Board of Health webpage related to the typical phases of agency rulemaking process. I have highlighted for you the gist of how this normally goes. I'm not going to bore you with this. You can read it if you want, but it basically lays out the steps that would normally take place if the Board of Health has decided that they want to make changes to the vaccination requirements. Normally what would happen then is the Board of Health would go through this agency rulemaking process. Now I have highlighted, as you'll see, the top one is the inquiry phase. CR 101 refers to the form that is required of the agency to prepare to submit it so that it may be reviewed by people on the code revisers section of Washington State. So essentially they say, hey, we're putting this out. We're thinking about making a change to the rule. Here's what we're thinking about doing. We send it out. It gets put in the revisor's office for publication in the Washington State Register, and then it allows an opportunity for some other steps to take place. So as you will see on the bottom of where we are right now, once the board files a CR 101 with the code revisor, we notify individuals who have requested to be informed about rulemaking activities, as well as public health partners, state government organizations that represent that they may be impacted by the rule. Normally, the Board of Health would send this notification out to these parties and identify that this is going on. Hey, there's a potential change coming down the pike. Here's sort of your notification for it. Here's what's coming. The next step then is what is CR 102? That's the proposal phase. And as I've highlighted, hopefully for you, had a chance to see it, the purpose is to announce the official public hearing, invite public comment on the proposed rule the board is considering adopting. So essentially, the CR 102 form, as it says, describes the rule, provides the proposed rule text, agency contact, as well as public hearing details, the public comment deadline, and the process. So this would be normally the second step of the process, that they are identifying for the public the opportunity for public comment. They're inviting the public for an opportunity to be engaged in the public hearing to sort of see and hear how things go. So this would be the second step, called the proposal phase, that they would normally need to go through. Before we move to the third phase, and I drink some water, does anybody have any questions about these two steps where we're at so far?
Remind us, who serves on our Washington State Health Board? Are those appointed by the governor?
That is a question I don't know, Commissioner. I don't know if the Board of Health members are appointed by the governor or not. I don't know that answer. I know generally who certain people answer to, but I don't know who appoints those members. And maybe Andre would have that information, or one of our medical professionals might know. I don't.
We can certainly get you the specifics. It's a little involved, but I'm happy to get that. I do want to share also that they do have staff who are technical advisors as well. So we can certainly get you all that information.
I can only speak from experience that I happen to know that they're political appointments by the governor, because one of the seats that is offered up is for counties of different sizes. So there's various representatives, similar in fact to how 1152 went through, and our health board makeup is very similar to what the health board makeup criteria that the State Board of Health has. And instead of the county commissioners appointing health board members under 1152 that passed, our State Board of Health is appointed membership by the governor.
Yes, and also the Washington State Secretary of Health is also a board member.
So moving on then to what would be the third phase normally, which is called the adoption phase, CR 103. That's the form, again, that identifies what happens. And this is then how the rule goes into effect, and sort of the process on how that would normally go. It's the adoption side. It's after normally the two prior steps had taken place. But I wanted to highlight for you in these sections, and I think it's important because they're, as it relates to some of the rules related to both the Board of Health and the Department of Labor and Industries, there are sometimes steps that are taken where these rules do not walk through all of these steps. So I want to make sure you all saw it. Sometimes the board, I have highlighted in yellow, may use abbreviated rulemaking process. State law allows agencies to do so. One is this expedited rule, CR 105. It's a pretty rare form, so I don't want to spend much time on it. I actually want to, if you can flip one more page, you can actually see the one that I think is probably the most in effect right now and has been in effect over the last year and a half, and that is under emergency rules. You'll see that in the very end. I've highlighted it. Emergency rule is a rule that the board may adopt that is necessary to protect the public's health, safety, or welfare, required to comply with federal law or rule. These rule changes become effective immediately upon the filing. So that's one major change is they become effective immediately once they are identified and adopted, and they are effective for 120 days. And that's important to keep in mind, because if an emergency rule has been adopted and no further continuance of that prior emergency rule is in effect, it will end. There is an opportunity for the Board of Health or other agencies like Department of Labor to continue some of their emergency rules beyond that period, but they need to take the steps in order to do it. The last sentence then, this rule is exempt from the filing of CR 101, analytical and public hearing requirements. Where a determination has been made by an agency that there are emergency requirements in order for them to adopt a rule or a guideline, the agency is allowed to adopt these emergency rules and bypass sort of sections 1 and 2 that we identified before, which is the notification, which is also the public comment and public hearing process. I'm sorry, was that I didn't hear you, Commissioner.
Oh, sorry. That was heard it noise. No word about it.
Oh, okay. Okay, I'm sorry. I saw it light up and I thought there was a question.
No,
So this is the Board of Health's layout about how their rulemaking process goes. And if you can turn to the next page, which is 52. So I'll have you stop right there. Perfect. So this is a portion of what's called the Administrative Procedures Act. This is RCW 3405. And this specific section is 350 that deals with emergency rules. The Administrative Procedure Act is RCW 3405. The Administrative Procedure Act is the normal requirements and layouts for any rule that is going to get created or adopted in any way, shape, or form. The Administrative Procedures Act also allows for this exemption under Section 350 for emergency rules. If you'll remember on our last page that we looked at, it identified that the steps can be moved beyond if an emergency exists. Here's the statutory requirement for an agency to determine if an emergency exists and then what may happen. I tried to highlight for you the main points of this, which is if an agency for good cause finds immediate adoption, amendment, or repeal is necessary for preservation of public safety, general welfare. The time requirements of notice and opportunity to comment, which were those steps 1 and 2 that we covered a second ago, upon adoption of a permanent rule be contrary to the public interest. So if that decision and determination is found by the agency, I skipped you forward to my handwriting in red that says then. So if that happens, if the agency finds that there is a need for that not to happen, then the agency may dispense with those requirements and adopt, amend, or repeal the rule on an emergency basis. The agency's finding a concise statement of the reasons for its finding are incorporated into the rule that gets created. It then walks you through sections 2 and 3 under the Administrative Procedures Act for emergency rules. It says if an emergency rule is adopted, this is section 2, it takes effect upon the filing. So that was that immediate effectiveness we talked about, unless a later date is specified in the order adoption may not be in effect longer than the 120 days after filing. That was 120 days that we just saw on the previous page. So if this happens, I wanted to make sure, and I figured I would get this question, if an agency does this and adopts this, what sort of response can happen related to anybody who wants to challenge it? Well, section 3 gives you your answer that on an emergency rule basis, section 3 says within 7 days after it's adopted, a person may petition the governor requesting immediate repeal of a rule adopted on an emergency basis by any department listed in 43-17-010. So it lays out sort of the process by which individuals may take issue with the emergency rules being adopted, and the steps for notice, hearing, and public comment are not allowed. This is the recourse. So this is my education class on codes and statutes to try and give you a big picture about how this process might go as it relates, again, trying to keep this as concise as possible on this concept of vaccinations as we're looking at. Again, this is all state-based areas I've covered. I will probably bore you to death with the federal if you want to ask me those questions, but in terms of what I've given, what questions does the board have for me?
This is a comment, James, but as a matter of public policy, though we can all agree on the benefits of vaccination, I think the mandate of the vaccination is where I personally draw a line. I say, well, listen, if we're supposed to be watching out for the public health of everybody, every citizen in the state of Washington, then the idea that we're going to terminate the jobs of first responders, of school teachers, of healthcare workers in relation to not taking into account even whether or not they may or may not have natural immunity, I think it's a terrible public policy to set, because clearly if our goal is to better the public health of the population, clearly terminating those kinds of people is not, in fact, bettering the public health. In fact, I might argue that it's worsening access. It's worsening the public health to terminate these people. And so I would just mention that as I think we can all agree on the benefit of vaccination. It's the mandate where I have the issue. It's mandating the vaccination. And then it's in turn terminating those that don't follow the mandate that makes it compounds the problem. So I would just make that comment publicly because I feel very strongly about that issue.
But Dr. Atterbury, I would share, my focus here was not on the governor's ability to do mandates, issue things under emergency proclamations. I wanted to stay focused just on, and I understand the comment, I stayed focused just on what the Board of Health, what the Board of Health can do, what the Department of Health can do, and the process. So I didn't spend any time on that. So.
Yeah, I was.
I'm sorry, go ahead.
To that, and that's a personal comment, as Nalia brings up. She's asking if that's my personal comment. Yes, that's my personal comment.
Mayor?
Yeah, thank you. So first of all, Dr. Atterbury, thank you, because I am in agreement with your personal comment about that. But my question, Mr. Elliott, and maybe just an entirely different conversation, is there has been this week some type of a ruling by LNI, and are they under the same category as the State Board of Health, for example, to the governor that they would require every small business to mandate vaccination?
Yeah, so I had a late night last night reviewing some things that have been coming down, and Department of Labor and Industries, I focus on the Department of Health here because the Department of Health has that sort of vaccination authority. So I focus there. The Department of Labor and Industries has been another governmental agency that's been involved in this process from the beginning. The Department of Labor and Industries has essentially been the enforcement of, as it relates to businesses, enforcing the rules related to how businesses can operate or not operate. And through this process, the Department of Labor and Industries has also issued, and again, I'm going to focus on this emergency rules area, has at times issued emergency rules related to actions that should be taken by employers. Keep in mind, Labor and Industries Authority is to focus in on occupational safety and health of employees within the workforce. So that's sort of their area, so to speak. I do know that during the summer and through the fall, I know the area of temporary worker housing was a big issue. I know my clients, several of them had to deal with these sorts of changes for the Department of Labor and Industries. And there's been a little confusion about what Department of Labor and Industries actually issued as a ruling this last week. So I do have that, and I will, another one that just came out in the last couple days. So I will also send a copy to the board of this new rulemaking order that came out from the Department of Labor and Industries But I don't know, Mayor Byers, that I would go as far to say what you just said. I don't think it's being accurately reflected that this is Labor and Industries requirement on all businesses to do X, Y, or Z. I think to the extent that anyone is reported that way, in fairness, I don't actually think that's what this new rulemaking authority says. But I will tell you essentially what it does say is it basically takes the idea that if the governor's proclamations related to mandates for vaccines for businesses has been adopted, which as of October 18th, it went into effect. What Labor and Industries has done here, and again, I will send this new rule. It just came out in the last, less than a week or so. This new rule essentially says that L&I has the authority to enforce the vaccine mandates as against those businesses that his proclamation affected. So I think anyone who has misrepresented this to say this is now a rule that requires every employer to do vaccinations, I'm sorry, that's just a misrepresentation. What the rule actually says, and you'll get a chance to look at it, is that L&I has the ability to enforce this proclamation against businesses who are not in compliance with the vaccination requirements under the mandate. So I'll give you the big picture. Right now, the governor's mandate that went into effect related to vaccinations are healthcare workers, we had state employees, and we had education system. So we had three areas that his proclamation had hit back in, I want to say that was in August when they were first drafted. They then went into effect as of October 18th. So that meant employers had an obligation to make sure they were in compliance with either an exemption had been granted or to confirm the vaccination status or to terminate the employee. That was sort of how the mandate came. This rule that was adopted last week essentially says that L&I now essentially has authority to make sure that any of those businesses that affected, again, schools, education system, healthcare workers, state employees, L&I now essentially, the way I read this, and again, this is sort of late night and early morning this morning, has the ability to enforce as against those employers the requirements of the governor's mandate, so that if those employers, and again, it's just focused on those, if those employers are not in compliance, L&I has now the authority to come in and I will say sort of enforce it to one degree and enforce the requirements under this emergency rule that the employees are to be protected. Again, the focus is from an occupational safety and health standpoint that Labor and Industries would be enforcing it to protect the employees who are working in one of these specific organizations. Does that make sense? Does that make sense, Mayor?
It does, thank you.
Yeah.
That's not, and I'm glad you clarified that, because reading just the news updates on it made it seem much broader than it is. So thank you for clarifying that.
Yeah, and Mayor, I will send this link to Victoria as well, so she can get it to each one of you and you can read it yourself. Now, to the extent that there's a different proclamation that comes out, and I'll cover this because I'm assuming this will be a question that comes up. To the extent that the governor issues a new proclamation related to other businesses, I would say that L&I would have authority under this rulemaking to also enforce against employers that future proclamation that comes out on vaccinations. So big picture, right now, this is giving L&I the authority to enforce those against those employers. But if the governor issues a new proclamation that identifies that, for example, every employer in the state of Washington that has over, I'll just take the federal one, over 100 employees or 50 employees or pick your number or whatever it is, the governor issues a proclamation requiring a vaccine mandate for other businesses, this rule does allow L&I to enforce any of those future proclamations as well. Does that make sense, Mayor?
Yes, it does. Thank you very much.
Okay.
Commissioner McKinney.
So So in layman's terms, then, Mr. Elliott, LNI has used the governor's emergency proclamation to cite the need to make an emergency rule without public comment to grant themselves the ability to enforce a possible future mandate from the governor regarding vaccine requirements of potentially all businesses.
So I would say right now, Commissioner, the LNI, and any time any one of these CR 103s, that is the rulemaking order, are put in place, it always identifies the authority that they have in order to do an emergency rule. And the basis is this Administrative Procedure Act that we're looking at right here, 3405-350. And then it will identify where the governor has issued a proclamation related to this emergency. They have essentially taken that to say, we fit as an agency, as Department of Labor and Industries, we as an agency fit into the emergency rule availability, which you see on your screen, that we can now issue rules without the, at least in this regard, without the hearing or public comment. That would be a correct statement in that regard. As it relates to future events, my guess is Labor and Industries would probably just update this rulemaking order for each additional proclamation that would come from the governor in theory. So I gave you the hypothetical that if a new proclamation was issued, L&I could use this. They could, but I actually think what they would probably do would be just to issue another emergency rulemaking order like this and just say the governor identified a new proclamation on October 27th. It covered these employees. We are now revising our prior rulemaking order to be able to enforce that. That's probably the better way to say it, Commissioner.
So another way too, I would say, perception is that by maintaining this emergency order, the governor, who also appoints our State Department of Health officer and who also appoints our insurance commissioner and who also appoints the Director of Labor and Industries, citing this emergency order, these agencies run by appointed individuals can circumvent the legislative ability of the people to create laws and debate, and as you've pointed out, have public comment. But we've successfully circumvented all of that only because we are still under an emergency order. So my question is, if we were not presently under an emergency declaration by the governor, would it be likely that these agencies would have the same ability to cite an emergency, to create their own emergency rules, to maintain this much authority that has not previously been provided to them, or at least articulated in this much of definition under RCWs?
So two things. I mean, I'm not going to get into political statements. I leave that to all you appointed and elected people to deal with those things. My job is to focus in here on the law. And I would tell you that to the extent that the governor's emergency powers are sort of taken away, I think reading this rule, and I want you to see it, because the requirement isn't just on the agency to say, well, the governor pointed to it and therefore we're going to follow it. Agencies on their own, Commissioner, could fine for good cause, which is section number 1 there. So in theory, if the governor's emergency order was taken away by himself or others who tried to challenge it, in theory, agencies like Department of Health or Department of Labor and Industries could still adopt immediate rules if you are focusing on what the language says here. So adoption is necessary for preservation of public health, safety, or general welfare, et cetera, et cetera. Those agencies could make those decisions on their own, irregardless of the governor's emergency power. I'm just telling you that as you read some of these, they are identifying that as one of their areas for good cause. But in theory, they could come up with their own version of what that good cause is, irregardless of what the governor's emergency powers are, Commissioner.
That is a wonderful point, which is why defining an emergency and setting boundaries to it would be a wonderful thing for our legislature to pick up when they go back this winter. It doesn't only apply to the governor, it applies to these agencies who have unelected leaders. Thank you, Mr. Elliott.
Commissioner Lindy.
Yeah, if I could, just a couple thoughts. First of all, James, thank you so much for putting this together. Obviously, you've done a lot of extensive research and legwork on this. I would be appreciative if you wouldn't mind sending this your highlighted version of all these RCWs and WACs out to me and perhaps the rest of the board as well, for just for reference. I would find it helpful.
They should be in your board packet, Commissioner, at least the highlights.
Well, I got the documents, but it's not highlighted.
Oh, I'm sorry. I had highlighted them and sent them to Victoria so that it would be highlighted for purposes definitely of what we're doing here today. But in terms of if you want me to send you my highlighted versions, I could do that, or Victoria can. And Commissioner, I didn't include all the pieces on here because the Secretary of Health has additional authority, the Board of Health, the Department of Health. I mean, each statutorily, they have been given authority to adopt rules. I didn't send all of that, but to the extent that anybody wants more of that, you can have it. But I figured this would be a good nutshell for everybody to work off of. So
what you have here in front of us is sufficient for my needs, but I appreciate your efforts on doing this. And it is just, I'll just echo some of the sentiments here. I mean, there's certainly a place for emergency rules, but it's kind of disheartening that this has become so commonplace now in the last year and a half, and that we're not using the regular channels. I mean, anyway, it would be nice to get back to doing things the way they were originally designed. Anyway, thanks.
Thank you. Any further comments?
Mr. Elliott, for the next meeting that we had, could you plan to, if we could just add on our agenda a follow-up regarding what happens between now and then? You mentioned that you're still reviewing this. I would like to have us review what has changed or any clarity that has been found pertaining to the mandate that potentially would be coming through Department of Health for school children, the expansion of the business mandate of vaccination, as it seems pretty clear. I'm just following the logical steps, but if we've got two state agencies making emergency rules to grant them the ability to enforce something, that usually means something's coming. So I would just be interested to already have these on the agenda so that you could fill us in at our next meeting.
Well, I will tell you this, Commissioner, I have never spent so much time reading through the Office of the Registrar or following these continued updates to see what's going on. I try and keep up as best I can with all this stuff. There is a lot. I will tell you this, I do know that the Board of Health has, sort of like we do, meetings every 2 weeks. I believe their next meeting is either on November 2nd or November 3rd. I do know because I think if I remember right, the Seattle Public School System was identifying that they had an interest potentially in writing a letter to the Board of Health, encouraging them to make changes to the vaccination requirements. I don't know if that ever happened. I just sort of saw that as a blurb, but the Board of Health will be having its next board meeting, I think on November 2nd or November 3rd. If anyone wants to dial in on that, you can. I'd go to the Board of Health webpage, and there is a sort of layout about how you can register and be a part of that meeting or see their agenda. But what I will do, Commissioner, is I will continue to look and see what they put together as their agenda, if there is anything else there, so I can report to this board. I do know, and I believe Victoria got to everybody either yesterday or the day before a draft letter that was coming from Wasalfo that I know that Andre had provided to me. Regarding local public health officers and their sort of encouragement of which did that make it as a part of the board packet, or did people get it? I'm sorry if I'm speaking out of turn.
James, it was sent, the draft was sent to board members.
Yes.
I sent it out to everybody individually.
I was under the impression that that was going to be new business.
Oh, I'm sorry. I didn't know it kind of related to this issue, so you've heard me talk for way too long, so I'll be quiet. Yes, Commissioner, I'll keep track of the stuff, I promise.
Well, thank you, Mr. Elliott, for such a condensed and short message and report. Appreciated. Any further comments or anything that we need to address?
Maybe Mr. Elliott, it would be helpful if you could, or if maybe the health board, it states here that, of course, according to the RCWs, within 7 days of the rule adopting, any person can petition the governor. Could you just describe how someone would complete that petition process?
Well, if I knew, I would tell you, but it looks to me like the remainder of subsection 3 answers that question. Or maybe it doesn't. Let's see. No, I'm sorry, it doesn't. It talks about the governor's required response. I don't know, Commissioner, how you petition the governor requesting an immediate repeal. I don't know that answer. I don't think it's in the Administrative Procedures Act. So, man, I wish I knew how to answer that. Maybe it's as simple as sending him a letter that says, "Dear Governor, please repeal." I don't know.
Boy, that's really sad. You only have 7 days to try to figure out how to do it. Well, that would be one more thing they could fix. Try to make it clear how you would complete that petition under such a short deadline.
Well, I want to be fair. I'm not saying there isn't a process, Commissioner. What I'm saying is I don't know what it is, and I have not researched that. As I was reading through this, I thought it might be in here, but I don't see it in this section. But I didn't look at that. I'm sorry.
Okay, great. All right. Thank you much, Mr. Elliott. Very concise report. And we'll move on now to any new business.
Yes, Mr. Chair, we have 2 issues of new business and then a thank you, a note of appreciation. So if I may, I'd like to tackle the first one, which is what we had discussed in previous meetings, which was the idea that we would discuss as a board if there was someone we wish to invite to speak to the board or discuss issues of relevance to public health to the board. And I wanted to share that we've had ongoing conversations with Jim Curtis, our county's coroner. He has shared public health concerns, as do we, about the impacts and effects of COVID-19 in other areas of our community around things like suicide, drug use, and so forth. So what I'd like to ask, and again, for the purposes of time, just quickly gauge the board's interest in inviting Mr. Curtis to join us, because there are trends that are happening with the losses of people in our community that are concerning to us and to the coroner. So if you would be interested, we can seek to invite Mr. Curtis to join us in future meetings and discuss some of those trends.
Would you prefer a poll on that or just my voice?
As you wish. I mean, I don't think it's a divisive issue. It's a reality that there are societal impacts to this. So if you'd like to take a poll, we can do so.
Let's take a poll. If you would, Ryan, please do that.
Probably want to make a motion first.
Okay.
I would motion
Yeah,
to
let's
approve.
somebody make a motion.
I would motion to approve having our coroner join us to speak on the effects and impacts of COVID on our community at our next board meeting.
I would second that.
It's been moved and seconded. Any further discussion? Hearing none, Ryan, would you conduct a poll, please?
Okay. Dr. Clary.
Aye.
Commissioner McKinney.
Aye.
Commissioner Lindy.
Aye.
Mayor Byers.
Yes.
Councilmember Duval.
Yes.
Dr. Atterbury. Aye. Commissioner Anderson.
Yes. Thank you much. And you'll make those arrangements, I assume, Andre?
Yes, we'll see once we have dates and times for our meeting, we'll see if it works. And so it may be this meeting or the December 1st meeting. But
Okay, thank you.
The second issue of business is to discuss the draft that we had received from the Washington State Association of Local Public Health Officials. That had to do again with the decisions around the potential for immunizations, and we want to be able to help folks understand the process. That was a draft form that came from local health officers, and it was discussed with the Washington State Association of Local Public Health Officials, which is the statewide association for health jurisdictions.
Troy, I'm so sorry. Can we have the letter pulled up so that the public can see the draft letter that we were provided?
Yes, that'll take a moment. Let me handle that. Pardon me for a second.
And Commissioners Lindy and McKinney, Eric Johnson at Wasac has been CC'd on this letter as well. There we go.
Very good. Thank you to Jocelyn and Victoria. Thank you for your patience to the board.
Yeah.
Again, this was sent out in draft form. We wish to share it with the board because it was a new change. It was something that we wanted to discuss. It's a bit complex, so I want to just share my understanding of it. Again, it's a draft of a request being made to the Board of Health discussing changes that are happening. Michelle Davis is the executive director of the board, and Keith Grellner is the chair of the Washington State Board of Health. I'm sorry, did you have a question?
No.
Okay, thank you. So my understanding is that health officers across the state are interested in discussing the implications of vaccination in schools and whether there is going to be potential for a mandatory vaccination of school children. And my understanding of what this letter is intended to do is to explain that they would like the process to flow through the Washington State Board of Health. So as we've discussed in James's previous presentation, there is a formal process regarding immunizations for school children. And what is being asked is to allow that process to work for this. I think one of the issues, and I'd like to highlight it, is as we've discussed, these are being distributed potentially through an emergency use authorization, which is different than the traditional process. So that's one of the things that's being called out specifically in this letter, is the hope that this would not be under an emergency use authorization. That's as much as I know about it, but I'm happy to discuss it. And
so Andre, yeah, just really quickly, as this use, the current proposal for use of this vaccine in 5 to 11-year-olds or 6 to 11-year-olds, that is under emergency use, isn't it?
Mm-hmm. Yes.
It wouldn't be a full approval. Yeah.
Yes, but the question is it mandatory? And so again, what we're discussing is what normally happens. And as a briefer, we have many immunizations in schools that are required and that are traditionally expected for children to take when they enter the school system. And so that is vetted through a process such as this. I did want to make the distinction that it's my understanding that the governor under the emergency declaration has the privilege to make a mandate. What is being asked here is to consider having it go through the more traditional formalized approach through the Washington State Board of Health.
Okay.
Are there any questions on that?
I would just comment that it seems really rational and logical that we would want to take this process very tentatively. And I applaud all the health officers who determined that they wanted to ensure that the normal process occurs, especially when we're talking about our children, and especially when we're talking about the potential of mandating something that's under emergency use. So, of course, voluntary, to Dr. Atterbury's comment, is always encouraged, but never mandated in this case under emergency use.
Any further comments?
Just that I concur with Commissioner McKinney's comments. Thank you.
Thank you. Any more? Go ahead, Commissioner.
Yeah.
Lindsay.
I guess I would just say that this letter, this draft letter seems like a prudent approach. I noted that when Mr. Elliott was showing the board's process for approval of vaccination requirements, that it also used the term full FDA approval. So I thought that was interesting. And of course, vaccines have done a lot of good for our public, through our school vaccination programs over the years. But I don't think I have a problem with the letter as written.
And the interesting news again is that, as James indicated, the Washington State Board of Health meets in a public forum. So this is really a transparency of governance in action.
Greg, could you provide a copy of the final draft? You mentioned this was a draft. So when and if a final copy goes out, can we please be provided a copy of the final?
Sure, sounds good. And it may have already gone out, but I'll check that and we'll send it to you. I don't believe there's a change. Thank you.
So is the question, is this just information to the board, which I think is helpful, or is this a question of the board as a policy making an agreement that our health officer would sign on board and be a part of that?
No, this is information only. Our health officer has the privilege to make a professional determination, but this is really about trying to be transparent with the board about a very fast changing issue. That's, again, we would not under normal circumstances to send a draft for something that was so new, but given the importance and acute concern around these issues, we wanted to be as forward as possible.
Thank you.
Thank you.
Andre, I appreciate your sharing this with us.
Thank you, sir. Are there other questions on this?
There's no other questions. That was new business. Any other new business?
Yes, the only other piece was my appreciation. I wanted to thank the board for adopting our budget. I don't take it lightly that this is a large budget in a very uncertain time with many, many complications. Your support and approval of this budget allows us to plan accordingly for next year, which we anticipate will be, again, complicated with the COVID rollout. So we just want to thank you, and again, my appreciation.
Thank you. Any other comments or questions? Hearing none, I will entertain a motion to adjourn.
So moved.
It's been moved to adjourn.
Mayor
Second.
Byers.
Moved and seconded. Any comment? Hearing none, all in favor?
Aye.
Aye. Any opposed? We are adjourned. Thank you all very much for your time and patience.
Thank you, everyone.
Thank you very much. Bye.
Good day. Bye.